Just 1 minute to waiting for the audience. Some colleagues should join now, I think. Okay. So welcome everybody, dear colleagues, dear ladies and gentlemen. We are here again, even online, but we are together in our next edition or a new edition of the Mediterranean Dental Meeting. As you all know that we organized the first edition online last September 2020, and this idea was created due to Corona or COVID-19 crisis. I'm sure that this is this is edition from this event will be amazing because we have 20 top international speakers from 17 different countries. Today, tomorrow, and after tomorrow, we will have them to show together their presentation who will discuss the latest trends in the future dentistry. Let me to say welcome today for our speakers from Albania, Tirana, Dr. Gorian Dimeraji. Welcome, Dr. Gorian.
Hello,
Ali.
Thanks.
It's
Very nice to see you here. And I'm very interested to watch your presentation. And let me say welcome to Dr. Alexander Khairallah from Beirut, Lebanon. Hi, Dr. Khairallah.
Hi, Dr. Ali. How are you?
I'm fine. Thank you very much.
For all the other participants also.
Yes, thank you very much, Dr. Khairallah. And let's say welcome to Dr. Anas Al-Misrati from Tripoli, Libya. Welcome, Dr. Anas.
Hi, welcome everyone. Nice to meet you, Ali.
Nice to see you. Nice to meet you and all of our colleagues. And our next speaker, Dr. Markus Engelschalk from Munich, Germany. Welcome, Dr. Markus. So you can unmute your mic, then we can hear you.
Hi there. Hi, Ali. Great to see you all. Great meeting. Even if it's online, but we're working on it.
Yes, thank you very much. And now we are going to start our schedule for the scientific program. And I will ask to keep Dr. Gorian just in the studio. Dr. Gorian, we are leave all now, and we let the cam and mic just for you. So the mic and screen is yours. You can share your screen for the presentation. And I would like to introduce a little bit yourself before we starting. Unmute your mic, please. Now it's okay.
Hi everyone. I'm very glad to be with you today. My name is Dr. Demiraji. I'm from Albania. I've been a professor in the university, chief of the head cathedra, OMF cathedra for many years. I'm a maxillofacial surgeon, and I practice in Tirana, Albania, where you can find me. And I practice mostly.
Hello everyone, we're glad to be here with you today.
My presentation today will be about saving teeth and implants, which is the new goal that everybody should have.
So can we start the presentation? I have to explain to all of our audience that the presentation will be recorded due to issue for Dr. Gurian. So, Dr. Gurian, can we start now? I think, okay?
Yes, of course.
Yes, of course.
Okay, thank you very much.
Hello, everyone.
Hello,
Glad to
everyone.
be here
Glad
with
to
you
be here
today.
with you today.
Let
My presentation today will be about saving teeth and implants, which is the new goal that everybody should have. Because for every dentist, the ultimate goal should be that teeth and implants live till their life's end. So, teeth and implants, to do so, need enough bone and soft tissues to support them. Implants, in particular, needs primary stability and also later on stability, and an acceptable emergency profile, which would allow that it can be cleaned and allow them to be there for many, many years. The good thing is that patients are accepting implants more and more as a solution, but the problem is that everybody wants less surgery as possible, and they want more aesthetic results than before. Which brings us to the big question and the big, exclamation: bone sets the tone, and soft tissue is the issue, which, as we know, is lost very soon after we do an extraction. So in 6 months, we'll have this dimension bone loss, as the colleagues suggest, but many other studies suggest similar results. So we need to turn to bone grafts and soft tissue grafts to regain what we have lost. And these are some of the reasons why we use these grafts. But what we look for in them? We look them to be with a short and long-term function, and possibly to turn over completely, to be a reliable scaffold, bioactive, to instigate remodeling. They should provide quick results, should be easy to handle, and to minimize the risks. Other indications to be considered are the grafting sites, age and state of the health of the patient, medications they are taking. Smoking is also important, and also other stuff which has to do with the skills of the doctor that is performing the procedure, and also patients' consideration, which are different, and they will make you choose one graft over another in order for us to fulfill them. What do we see in practice? Well, many times the graft is lost. We have bone recession. We have unpredictable results, short and long term. And what can we use? Allografts, xenografts, and synthetics have been used, and also autologous bone and teeth. The last one are the best accepted from everyone, but the last one has got also some, issues, because you need some place to get them. And these are the places where we normally look for an autologous bone graft intraorally. Extraorally, of course, we can go on and search for them. How do you harvest the autologous bone intraorally? These are some of the instruments, and these are some of the old-fashioned instruments.
One of my favorite instruments to use is this osteotome, which is called Unica. The beauty of this instrument is the fact that with small probing just before, without water and with small rotations, you can get plenty of bone from the implant site in form of bone chips, which then you can later use for other grafting procedures around the implant, or even away from the implant site, in order to restore as another one that I really like and enjoy using is the scraper. As you have seen before, I really like this instrument. It's easy It's fast and allows you to collect cortical bone to use for your grafting procedures nearby or in distance. The bone chips collected are really nice and very good, so the use of it is really to be considered. Another very good source of autologous bone grafting is the tooth. Of course, it requires a tooth which needs to be processed in order to be used, but this is really a good idea. So please, as you can see, there are about 20 million teeth extracted every year in the US. Please don't discard them and use them to do a graft, which is really good and in quality that equals the bone graft. So it is easy, and the procedure to do this takes about, say, 7 to 8 minutes, and afterwards you can transform it into a clean graft, bacteria free, which can be used. If you want then to improve it even further, you can make it sticky tooth, as in this real-time video, in which you can see that the bone graft provided from the tooth, so the tooth graft, is then enhanced with unsettled fibrin from the BCGF procedure, which are crushed in it settled clouds of fibrin in order to augment them even further with growth factors and make it much better as a sticky tooth, which is a really good grafting solution that I've been using for many years now and provides with superior quality, good stability, and can be used in all the possible procedures of grafting. As you can see here in real time, this graft is really mixing up and becoming sticky. So this is about it. Now it is all settled and you can use it in your grafting procedures. Well, everybody here will agree that the autologous way is the way to go, so not much is to be said to contradict me in this one. And also, the autologous tooth has overcome some of the deficiencies of autologous bone and is an easy procedure which why not everybody should use. And it's been tested for many, many years. And also the recent, techniques that have been used, like PET and root submergence, have also follow-up of many, many years. So it's good to know that this procedure is safe for your patients and it should be used. Also, another ingredient that we need, as we said before, are the soft tissues. So these are the places where we normally look for in soft tissues. Palatal and tuberosity, maxillary tuberosity are the ones that we prefer. Also displacement grafts. And everywhere where we can find some a quantity of autologous soft tissues, that is good to use. And many techniques should be used to improve what we already have. This one is soft brushing. This is a technique that allows us to stretch the fibers in order to make place for a new bone that we are going to place. You can then place other small soft tissue grafts.
But first of all, you have to make place for this graft to be placed into mouth.
We use a technique with a small incision, as you can see, the tunnel superiostal technique, which can allow you to place the graft underneath between the bone and periosteum in order for this to then be maintained and not to move from position. As you can see with the soft brushing kit, as before, in the small incision made, we make place for our graft of hard and soft tissues so that we can then have this small wound which can be sutured easily, and the patient is also happy because it will not cause him a big wound in his mouth. And for us also it's very nice because we can have this small incision to heal, and this will allow us not to have problems in the future. Normally we have very small problems with it.
Another source of autologous soft tissues are the fibrin clots that, as I told you before, I get with the BCGF system. So we get the blood from the patient, we centrifuge it, and it is divided in several compartments, or let us say several straits, stratificated in at least 5 according to weight. The first 2, or let us say the first 3, are the most important for us. The serum, which is very good to be used to wash the wound. The white buffy coat, which is the fibrin that we use often, and then directly connected to them are the growth factors and the CD34 plus, which comes from the blood. It's an easy procedure and it's done in like 10-20 minutes, but meanwhile you can continue with your surgery. Many doctors are doing similar procedures around the world, and everybody is giving it's going on with them because they are easy and they have a good performance. Some clinical cases, as you can see, I have extracted and used many years this grafting, so I have much to show about. And as you can see, there are many cases with sticky tooth. Some of them I'm going to demonstrate in this presentation. Well, as I told you before, the goal is to preserve the teeth. This one is one of the classical problems. We extract massive cyst. This one was from 21 till 26. And we also have got like 4 infected wisdom teeth. And the situation was furtherly worsened by the fact that the patient had non-occlusal trauma and hypothyroidismus. The patient diagnosed this case a couple of years earlier, but due to the fact that it was such a big cyst, she was scared, and many other doctors told her that she should go with big grafting, iliac crest, to get enough bone to fill this big hole, which in the moment when she came to me was with around 4.5 centimeters. But at the moment that the patient get this aspect, there is nothing more to wait. She started some therapy, some endodontic therapy before with these 3 teeth, 21, 22, and 23, which was done to, try to reduce the mass of the cyst, which, as you can see, is big enough. And this is the hole in 3D. But it wasn't successful. We treated the other 3, as you can see, in a very conventional way, nothing fancy. This is the measurement of the cyst in every teeth. And we had also a witness that thought that it was impossible, but afterward he became one of our, believers. So, as I told you before, I extracted the 4 wisdom teeth and simultaneously did some graft in order to make this like 16 cc that we needed. This 4 wisdom teeth provided us around 12, and the rest of it was biomaterial. And lots of BCGF clots. This is the cyst, as you can see, when we extracted it. We corrected a little bit. The margins, as you can see, they are still sharp because we didn't want to lose the scaffold provided from this minimal bone. We treated the apexes, nothing important. Laser was also used to hygiene this hole, laterally a big hole. And this is the biomaterial placed inside. And we also placed a membrane, but this membrane was not to do something, because normally I don't use membranes, because BCGF clots are more than enough in form of membranes. But this one, as I told you, it has these sharp margins that I didn't want them to cut my soft tissues. So I placed this membrane, which is a simple collagen membrane, to protect this bone in order for me not to have problems during the healing. BCGF, lots of it. This is the wound closure, which is really important in this case. This is a situation at 1 month after surgery. We did an X-ray at 1.5. As you can see, everything is stable, and the CBCT at 9 months. This is the situation at each site, and as you can see, there is bone everywhere, and we lost none of the teeth in the procedure. At 1 year, we performed some treatment to these teeth with posts, fiber posts, and also other treatments in the other teeth, because we wanted to improve the occlusion. It's very important that you have a stable occlusion in these cases, so that we're not losing this tissue that we have. So this is the situation, and now the case is like 4 years old and is doing very well. The patient has no problems. Is continuing with her life. Another case, I started using in orthodontics with one of my approaches combined with Dr. Baruti. So we called it the Baruti-Demirati approach for corticotomy. And this is one of the cases in which we performed also some bone grafting. As you can see, the frontal area in this patient, which is a doctor, is very bad. No hard tissues at all. And there is here this tooth to be uprighted. And so this is the uprighting device. We did corticotomy and bone grafting in the frontal area, as you can see. This is the graft, and this is covered with BCGF. And we did corticotomy here, partial corticotomy to upright this tooth. Is about 7 or 8 years old, this case. So as you can see, the follow-up is not so small in these cases of mine. And after the tooth was uprighted, an implant was placed, and we took a CBCT to see the improvements. And as you can see, there is new bone everywhere in this frontal area. So the situation is much better than before we started the treatment. An implant was placed, and then that was it. Another case with class 1 malocclusion, retained 13 and 22. Lots of other problems with thin gingival biotype, insufficient bone coverage overall. we decided to go with corticotomy with BCGF membranes covering and orthodontic treatment in the second stage and implant placement in the third one. This is the initial situation, but if you see the 3D and the intraoral pictures, the situation is much worse than it looks in the X-rays. So this is from where we started, corticotomy with our method, covered later on with bone and BCGF membranes. This is suturing and going on with the orthodontic treatment, which starts immediately after surgery. After alignment, implant was placed, number 23. And this is the BCGF, this is the CBCT situation afterwards. As you can see, there is lots of correction to that initial disastrous situation. And this is the situation now, well, so to say now, because it's like 5 years old. And as you can see, there is much improvement in hard and soft tissue everywhere, and the patient can smile now. Another case, which is even more dramatic, a 13 years old patient, class 2 division 1, high angle, bilateral crossbite, anterior open bite, V-shaped maxilla, mouth breather. The frontal teeth has got a densification with vestibular roots exposure and bimaxillary in the frontal area. The treatment was RPE, McNamara type before, after split in the middle of the palate, extraction of 14 and 24, and then the treatment with the Baruti-Demirati approach with sticky tooth and BCGF membranes. This is the situation before the treatment started. So as you can see, the maxilla is much too narrow to start with. So first of all, we started with expansion in the middle. This is right after it. And then we extracted the 3 rooted premolars. As you can see, 3 rooted premolars, which are almost impossible to move according to the orthodontist. However, in order to create space, they were needed to be removed. So I used them as sticky tooth and added some biomaterial as well. This is the corticotomy procedure, piezo, we use. As you can see, the sides are covered with biomaterial and then with membranes overall. Same procedure in the lower jaw. And then this is after the surgery. This is the maximum swelling that we have in these cases. So as you can see, nothing important. This is the situation during orthodontics, accelerated orthodontics, because every 2 weeks this orthodontic treatment is accelerated. And this is the situation afterwards. This is the intraoral one. This is then the aspect extraorally in the X-rays. And as you can see, there is new bone and new soft tissues everywhere. So the patient has got new life, since she is also a very young patient and she can laugh now with all her heart. Another patient in which I decided to graft, something that I do often is grafting the wisdom teeth after extracting them. But in this case, I wanted to graft the anterior mandible, which, as you will see, is very deficient in bone. The patient has undergone orthodontic treatment in her youth, and now the result is this sack of bone in the frontal area. These are the 2 wisdom teeth, lower wisdom teeth extracted. This is the sticky tooth provided. And this is the incision with the method I showed before. I placed soft tissue and hard tissue simultaneously. And as you can see, the situation in each tooth from 43 till 33 is much improved. And there is new bone vestibularly that was not before. This is the situation in the X-ray at 6 months. So nothing was done. Another case, vertical fracture of 15 resulting in bone resorption and also bone missing vestibularly in 16 and 14. We decided to immediately place an implant because the patient is a businesswoman and she didn't want to stay a minute without her teeth. So this is the fractured tooth. And odontically treated tooth are used without problems for many years now. And I'm glad to be one of the first that starting using them and also to publish a case with orthodontically treated tooth. Of course, you have to clean them well from all the, rests of endo material before you start to use them, of course. So in this case, as you can see, there is bone loss also in these teeth, which I wanted to improve with my surgery. So we extracted the tooth pieces, cleaned very well. We detoxicated them with blue M gel, which I often use in my procedures. These are the tooth pieces cleaned and ready to be transformed into graft material. Some more biomaterial to add and bone chips, of course, which I like to mention, but I almost always use, because since I told you that the scraper is one of the accessories in my surgeries, of course, it is some autologous bone to enhance the situation. So this is a situation. Cervical VPI was used to create this emergency profile, which is a two-part system that includes the surgery and prosthetic part. So you choose the right surgical tool, and then you can make an healing abutment which is perfectly shaped as the tooth you are about to extract. And I used it, and this is then a situation afterwards, after we created the crown, also more blue M gel. This is a situation. I added some some retromolar soft tissue graft because I wanted to improve it further. And this is the comparison in this teeth before and after grafting. And also this is the implant. As you can see, there is bone to support it everywhere. This is a result after the removal of the sutures. And this is healing at 1 month and at 6 months. As you can see, it is almost like the rest of their teeth. Another patient, 58 years old with periimplantitis, unconventional treatment, bone loss, vitamin D, avitaminosis. Well, as you can see, this is the CBCT and the 3D reconstruction. There is some bone loss, and the patient had complaints in this lower area. This premolar was not endodontically treated, and this was a bridge that was holding one implant and 2 teeth. So the implant was in the middle. Well, also there was big problems in the upper jaw, first quadrant. As you can see, this 2 teeth has got almost no bone palatally. Of course, they aren't so good, so well placed. But however, the patient didn't want to remove them for the moment. So I decided to go for it and decided to, graft it and try to save this teeth also. So this is the preoperative situation also in this implant in the lower one, number 46. We reconstructed the number 45, I believe, and number 47 was the implant in mouth, and we place another implant, number 46, sticky bone, and another implant, number 35, was placed. This is the cervical emergency profile. As you can see, very nice, very naturally shaped, and deep enough in this case. It's like 6 millimeters deep. And also we improved the bone in all the other implants, existing ones. As you can see, there is bone in both sides. And my new implants, of course, they got their share of bone, of course. And we also improved the bone in the frontal region so that the natural teeth are also held in position. And we are going to do some more grafting in the future for the upper jaw so that the situation is better and the patient has got his teeth for a very long time, possibly till the end of his life. So these are my implants. As you can see, the emergency profile and how deep they are. And this is the aspect, so how they look after prosthetic treatment of zirconia porcelain is finished. And this is the existing implant, which is, of course, much improved from before. Another case, a patient, female, 62 years old, implant and bridges done 15 years ago with bone resorption in the entire upper jaw and some infections in the frontal area. So teeth from 12 to 23 were treated. Immediately was placed grafting and BCGF membrane. And afterwards, something occurred that I will explain you later on and needed me to perform a socket preservation. So this was the situation 15 years ago. And I placed a couple of implants 15 years ago, which are not what I should have done now, but however, for the time, they were okay. And the fact is that they are in mouth for 15 years, so I haven't got much to, complain to myself. However, this is the situation now. Like 3 years ago, as you can see, there is bone loss, which in my opinion is a physiological bone loss, and nothing to do with what we call, or what I believe should be called, periimplantitis. However, there is bone loss everywhere in the implants and also in every tooth, and some changes in the apexes of the frontal area, which I decided to treat simultaneously, laser cut, and then afterwards we exposed all the apexes, cleaned with piezo, and BCGF was also used. MTA was used in the apical areas, and then I performed some superiostal tunnels in the both directions, as you can see. And this is the soft brushing. And then afterwards, I started placing my graft with hard and soft tissues in the entire jaw, covering it with BCGF membranes and suturing it. Also Blue M gel, as you can see after suturing. This is the post-op CBCT. And as you can see, those implants will be there for many years more. So also most of the teeth will be still there. And why do I say most of the teeth? Because we had a small problem with number 23, which cracked during this time. I can't know, but malocclusion was one of the things that was suggested to me. that caused this crack in this tooth. So afterwards, I had to, extract it, a vertical fracture. I grafted it, added a little bit of biomaterial as well, and I did a socket preservation in this area and placed a provisory bridge for the healing times. And then the bridge was changed. It's not, so to say, the maximal aesthetic result, but the patient is like 65, so it's nothing that she cares about aesthetic in this moment. And of course, there are some other changes to be done, but the patient is unwilling to do so. So we have to consider that too. And the situation is now stable for like 3 years, and I have nothing to regret for my treatment. And now the implants are also stable. Well, this is the one case that is not something that I would recommend, but it is one case to show you what you can do with grafting nowadays. The patient has got only 3 weeks, so he had only 3 weeks because he lives abroad and didn't want to stay without teeth because of his job. But there was no bone in most of his mouth. The only teeth remaining to use was 17, 12 till 23 and 26, which were prepped, and I made a bridge out of them, which was provisory for my opinion, but till now it's still a solution for his mouth, and he doesn't want to place implants soon enough. But let me tell you what was going on. This was the situation a couple of years before he came, and this was the situation in the CBCT after 2 years from this panoramic X-ray. So most of the teeth here are boneless and almost gone. This is the CBCT cuts. And what could I do? I extracted them and flaplessly grafted with sticky bone, with sticky tooth provided from this teeth, after cleaning it very well, of course. Piezo was used, lasers, also Blue M solution and gel was used to detoxify these areas. These are the teeth extracted. This is the sticky tooth that we had provided from them. We placed it, as you can see, flaplessly. And as you can see, the teeth are already ready to have a bridge over them. And also with the tunnel technique, in the frontal area, I also placed some bone. This is the serum that I always use before placing the graft, because the serum has biotic properties, antibacterial properties, and of course it also improves healing. As you can see, sticky tooth was placed also in the frontal area, and I placed this provisory bridge directly after the surgery. And within the 3 weeks, as I told you, without even removing these sutures, I placed this full mouth bridge in metal porcelain, which since he was going to come in 1 year, I wasn't sure that the provisory bridge will do the job. But this mistake costed me the fact that the patient is now happy with this treatment, and this is the X-ray he showed. He sent it me a couple of years later, and he came then later on, and this was the situation with these bridges, and he doesn't want to change it, but he had the small problem in the lower jaw in this area, number 43, and he wanted to, treat this infection here, which created this enormous hole. And I decided to treat it. And this is a recent treatment. And I did it also flakelessly. And this is a situation after my grafting. And of course, splitting the teeth together. Splinting the teeth together and creating the contact point here, because it's imperative if we want it to succeed. It should be, it shouldn't be loose. And I'm hoping to get a good result here also. And I'm hoping also that the patient will change his bridge to a couple of implants in each side, so that his situation is stable then. Well, another case, a patient 60 years old with unilateral crossbite, is a bruxer with a deep bite causing abrasion. He is also a diabetic and with hypothyroidism, and he's got like 4 infected teeth. And we decided to extract them and to place bone everywhere and to treat him orthopedically, so full mouth rehabilitation, so to change the situation he is in for the moment. This is the intraoral view. As you can see, it's something very bad. The pre-op CBCT shows us this situation. There is also bone loss caused by malocclusion. And this is how he closes his mouth, as you can see. Since he had pain, we provided with an emergency bite. And then after a couple of months, I decided to go with my treatment. Botox was, of course, used to, reduce mesenteric strength, so to say. And this is the full rehabilitation, which started before surgery. I extracted the teeth, as you can see, added, of course, biomaterial and bone chips, because it's a big quantity of bone to get. This is the post-op situation. Directly afterwards, the provisories were placed in the right height. So he's got now a good third, a good dimension in this in the lower third of the mouth. This is after 6 months. As you can see, there is new bone formation everywhere. And we placed our prosthetic treatment in both jaws. He didn't want to get implants. And since it was a full mouth rehabilitation, we had to agree. And of course, it's not that every patient should have implants. Teeth are good enough, I believe. And I'm going to show you now a couple of cases with periimplantitis and finish with it. So, periimplantitis is one of the problems of our time. And of course, it's in many times, exchanged with the natural bone loss that occurs in every patient mouth. But this one is a female patient of 30 years old that I know for like 16, 17 years now, because she came with a trauma, and this trauma caused her to lose her tooth, number 21. And then we treated her at the time. So this is the situation in 2004. We treated her, and this is the situation now. So orthodontics was used to create space for an implant. And since the patient was like 12 or 13 at the time, we placed this kind of solution to, mimic and make her have a tooth in her mouth. And then in 2017, when she was adult enough, we placed an implant flaplessly at the time. It was the trend. And as you can see, this is the implant placed. And the prosthetic treatment in 2007. This is then 2017 when she came back wanting, now she's adult, she's architect, and she wants to improve her situation. So I decided to perform surgery with grafting in a tunnel technique with FGG, sticky bone, and BCGF to improve the situation in this implant. This is the FGG site, which I cover with BCGF membranes and then suture. And then we changed the prosthetic in 2020, so last year. As you can see, this is the situation pre and post operatively. And I also changed the situation in our, adjacent teeth, 11 and 22, of course. This is the situation now. As you can see, no bone with plenty of bone vestibularly. And this is then the aesthetic result we achieved now. So this is the before and after. Another case, the last one, patient 45 years old with periimplantitis in an implant placed like 10 years ago or so from me. And the abutment has been moving for 3 years, and the patient didn't tell me nothing till the moment that he came out, which was too late, and there was an enormous loss of bone. And he's also a hepatitis carrier, but just nothing else to show to his anamnesis. And I decided to do something that I have seen from another doctor done, but I haven't seen it done in a periimplantitis. And this time I decided to do it. So this was a situation like 11 years ago. I placed an implant. This was the situation. And then he comes around 1.5 years ago with a broken superstructure, which I removed, which left this situation here. Well, I tried to, justify my error, so to say, in doing a bone ring graft from the wisdom tooth number 48, which had to be extracted. And this is the partially decalcified tooth ring after you remove the enamel, and the rest of it is used as grafting, and some more bone was also used, some more grafting material was used, so extraction. And this is then the situation after sutures removal. And this is the situation at the CBCT at 6 months. And this is the intraoral situation. It was pandemics last year, so even though I wanted to get good pictures, it was very difficult. So this is what I've got. And I was hoping the patient to come back, but since, as I told you the first time, he didn't come for, like 7 or 8 years, it's not that I'm expecting him to come again. I called him several times, but not to be seen. So. Are you not entertained? I hope with this to have finished. Another top 100 doctors to be mentioned here, which says that socket preservation should be the standard of care, and every socket has to be grafted every time, which I would agree. And with this nice old picture showing dentists at work and giving you some more personal information on where to find me, I'm finishing my presentation. I hope you really enjoyed it, and I thank you for your patience. Thank you very much. Thank you, everyone, for your attention to my presentation today. And I really enjoyed being with you.
Thank you, Dr. Gurian.
Of the presentation.
Yeah. Thank you very much for this nice presentation, who was supported with many clinical cases I love it and enjoy it, and I think everyone who concerning about implant dentistry like this presentation. Many thanks again. How is the weather right now in Tirana?
Thank you. Oh, the weather is fine. You know, it's November and it looks like July.
Ah, okay, perfect. The same here is in Tripoli, Libya, and I think everywhere. Yeah.
Yeah.
So thank you very much. Have a nice
Thank you.
evening. Have a nice weekend, and
The
hope to
same
see
to you.
you soon in person. Thank you for this opportunity. Bye bye.
Gladly. Bye.
And now it's the time to say welcome to Dr. Alexander Khairallah from Beirut, Lebanon. And the next one after Dr. Khairallah is Dr. Ihab from Dubai, UAE. Welcome again, Dr. Khairallah. Please unmute your, yes.
Okay. Hello, hi Ali. I'm very pleased to be with you in this second version of your online congresses. For sure, I would like to thank Dr. Gore for his wonderful presentation. And let's begin. Before beginning, I will have to stop my cam in order to have the whole strength for talking over the internet. Okay. Ali, I think I have to share my screen again.
Okay, no problem. Take your time. Waiting for you.
Okay, I did. Because we had time during the sharing. Okay. So this is it.
Yes, it's okay.
Yeah, my presentation for today will be about microradiographical mandibular anatomy as related to implantology. For sure, if we are going to do some implants in the anterior mandible region, or only do some bone harvesting, and we saw lots of good bone harvesting with Dr. Gorek before, or even a simple enucleation of the cyst in the anterior region, we need to know the exact anatomy of the anterior mandibular region. What I mean, first of all, some of the landmarks are the mental symphysis and the mental fossa. As you know, on 2D imaging, for instance, the intraoral bisecting technique, we cannot manage to have the whole anatomy of the anterior mandibular region. We only have the mesial and distal parts and some, let's say, of the mental ridge and the mental symphysis over here. Okay. Even when we are talking, Ali, is there any problem? Okay. Even if we are talking about, I'm sorry, but I'm trying to follow it over the internet to see.
It's okay, Dr. Khairallah.
Oh, you are seeing
No
this?
problem.
Okay.
No problem. No problem.
Okay. I'm trying to put it on my cell phone in order to see if I'm live or not. Anyway, if we are talking about panoramic X-rays, for sure, as you know, panoramic X-rays is a series of tomographic cuts going from one side of the mandible till the other side of the mandible. And at the end, we have the whole panoramic X-ray. And also, as I said before, it's a 2D representation for a 3D anatomy. And as you can see, the anterior mandibular region is also seen mesial to distal. And we cannot see the bucco-to-lingual aspect of the mandible. Let's say a case. As you can see over here, we have lots of bone height. We can easily place whatever length of implant we want. But let's look at the cross-sectional, the third dimension, and wait a little bit for it in order to see the whole truth. And as you can see, we only have 3.4 millimeters, around 3.4 millimeters of bone. So we don't have enough bone to place an implant. Talking about the diameter of an implant, we have to go for some bone graft before doing it. Even if we look at some orthoocclusal X-ray, as you know, the orthoocclusal X-ray, we can manage to see the whole buccolingual aspect of the mandible. But look here, is it the real width of the bone? Let's look at this case. Look at the shape of the mandible. It's like an L, a capital L. So if we'll take an orthoocclusal X-ray going from down till the occlusal part, this is the direction of X-rays, and this is the length, the width that we can have, but in reality, this is the one where we are going to place implant. So we have a superimposition from this part over the other part on an occlusal X-ray, and this is why we have the whole width as it was represented over here. So whenever we are placing implant, we need to know the third dimension, which is the buccolingual aspect of my anterior mandible or any other parts of my maxilla and mandible. And here we can place implant in a convenient way, according to the length and diameter that we have. Sometimes we do have enough bone to place an implant, but sometimes we don't have enough bone. Or as you can see over here, we have a length of bone, but the shape of the bone is like a knife edge, and we cannot place implant before doing bone graft or other procedures during implant surgery or before implant surgery. So the best way to know the anatomy in its 3-dimension is cone beam CT. And as you know, the cone beam CT will use a cone beam shape of X-rays doing 180 or 360 rotation all around the patient's head. Clinically, it's like a panoramic, but instead of taking 2D image, it will take a 3D image. Like if we are doing X-ray for our patient from all his aspects, buccal to lingual, upper to down, and mesial to distal. Let's look at this case. As you can see here, we do have lots of height of bone, but look, in reality, we have a knife edge of bone over here, and this is the actual length where we are going to place an implant. So probably here we are going to do some shaving for the bone before doing our implant surgery. In order to have a good 3D representation of the buccolingual aspect of our patient, we have to do what we call a panoramic mapping. It's a series of points and lines that we are going to draw over an axial cut, a chosen axial cut, and it has to be very accurate. We are not relying on what an X-ray laboratory gives me. Why? Because as you can see over here, I adjusted the point in order to have the correct shape of my mandible. And from this shape of my mandible, I will have all the cross-sectional cut on which I'm going to place an implant. So what's the problem if we are not drawing a good panoramic reconstruction? Let's see over here. As you can see here, we have the series of dots and lines, and they are not accurate at this point. Okay. And we have this thickness of bone anteriorly. Those are the genial tubercles, and we are going to talk about the genial tubercles a little bit later. And I'm doing some measurements for the residual basal bone. And this is the length. It's about 7.7 millimeters. And only by adjusting my points in order to have a good representation of my mandible, and as you can see, my 7.7 millimeters are no more accurate. So this is only by adjusting the points over here. So if I'm working on cross-sectional cuts that I got from a center of radiology, drawn on a wrong panoramic reconstruction, I will have some difference into the reality, what I will see into the patient mouth and what I have on my drawings. Another problem, the panoramic reconstruction is a thin cut of my patient. So this thin cut will be placed wherever I'm moving it. As you can see, if I'm passing through soft tissues, it will show the soft tissues. And if I'm passing through teeth and bone, it will show the teeth and bone. Let's see this case. This is a panoramic reconstruction. And as you can see anteriorly here, I can see a radiolucent images in relation with all the anterior teeth. So it can be a periapical cyst or whatever else as pathology, let's say a traumatic cyst or whatever. I'm not discussing pathology now, but let me show you when I redraw the panoramic reconstruction, and as you can see, we don't have any radiolucent image anteriorly. Why? As you can see here, this is the shape of the anterior mandible, and we do have a large concavity due to the mental fossa. And this is the cut. Those are the mental fossa, as you can see over here. And this is the cut of my panoramic. As you can see, my panoramic is passing through teeth, the crown, the roots, some of the bone, the soft tissue, and then the bone. And this is why I got this radiolucent image over here. So this is not pathology or anything. This is the shape of the bone. And if you look carefully at your patient, you can see that he has a big depression over here, which will reflect the bony shape of the patient. So whenever you are looking at the patient and you see that he has a large depression, as in this case, think about the soft tissue copying the hard tissues, and the patient will have a concavity over here. So if you are placing implant over here, think about having a problem when you are placing implant. Or even, as I did before, if you are seeing a radiolucent image, think about having to move your panoramic reconstruction in order to have the whole reality. So as I said before, we have two situations or even three situations. The first one, we have plenty of buccolingual bone, and we can easily place implant into the bony envelope. What are the other situation? Is the first one is where we are placing implant in a poorly bony region. As you can see over here, the implant is placed with some of the threads being buccally, and this is one scenario. And the other scenario is in the same situation, but the implant is placed more lingually. And in different cases, we have different consequences. Let's see the first one. As you can see over here on 2D representation, this is like a panoramic reconstruction, and it's representing a 2D view of the patient. We are seeing two implants. They are perfect, parallel to each other, and parallel to the adjacent teeth. But when we looked at the cross-sectionals, as you can see, the implant, the right one, is placed out of the bony envelope. This is the 3D reconstruction of the patient. So what are the problems? The problems is sometimes we will lose our osseointegration, and sometimes the implant is osseointegrated, but as you can see over here, we are seeing it by transparency, and this can lead to some problem in the aesthetic region for the patient, or a problem in reinfection and a dehiscence of the flap, and also losing the osseointegration. To cure the situation, the dentist tried to put some bone graft. As you can see over here, those are the bone grafts, but still the implant is outside the bone, and it didn't finish well. So in this situation, we may have some loosening of our osseointegration, and in most of the cases, this is the case of some aesthetic failure. But the more dangerous situation is whenever the dentist perforate lingually. As you can see over here, that an implant placed in a wrong buccolingual direction, and it pierced the lingual cortical. And if you look a little bit at the literature, you can see that lingual plate perforation, especially anterior to the canine region, can easily injure blood vessels in the floor of the mouth and cause life-threatening hemorrhage following implant placement. and care should be taken to recognize situation where this complication may occur. Why? If we look a little bit at the irrigation for the sublingual space, we have the external carotid artery giving two arteries, main arteries, the deep lingual artery and the sublingual artery. And the sublingual artery, in this case, it's a type 1. In 63% of the cases, it's irrigating the anterior region of the floor of the mouth. In type 2, 5.6% of the cases, we have also a branch of the submental artery, which is also a branch from the external carotid artery, also giving some irrigation for the anterior region of the floor of the mouth. In the third dimension, in the third situation, in 29.6%, we have the submental artery without the sublingual artery giving this irrigation the anterior region. And finally, the fourth type, in 1.8% of the cases, the submental artery without the sublingual artery and the deep lingual artery, it's only the submental artery is irrigating the anterior region. And if we look carefully, we can see that in type 2, 3, and 4, where we have a mix between the submental artery and the sublingual artery, we have the submental artery, which will perforate the mylohyoid muscle and takes a roundabout route to travel near the surface of the mandible. The percentage occurrence of arteries traveling between the sublingual gland and mandible in type 2 and 3 and 4 is 55%, and it's higher than in type 1, which is 8.8%. So what's the problem over here? Those are the sublingual arteries traveling too close to the lingual border of the mandible. And any perforation over here for the lingual cortical will hit the sublingual arteries passing too close to the border of the mandible, at the canine region especially. And if we look more at the anatomy, you can see that the diameter is between 0.3 and 3 millimeters. Posteriorly, it's away. It's 4 millimeters away from the lingual cortical of the mandible, and the anterior region, it's 2 millimeters away from the lingual part of the mandible. And this can cause a problem. If we are looking at the height, usually it's about 14.5 millimeters from the crestal border, but sometimes due to some bone resorption, the anastomosis or the pass is higher. So if we perforate, we are not in the bony envelope, and if we perforate either with our drill or our implant, we'll hit the artery. And the artery will bleed into the sublingual space, and this can be only a little bit as some blue bruises for the patient, or a little bit more, causing some medium hematoma. And the third one is very dangerous when we have lots of blood coming out. And as you can see over here, the tongue will raise up and it will close the respiratory space. And the patient will die or will have some problem breathing. So he will finish by having some intubation at a center of reanimation. So we should have in our clinic what we call the Gadel cannula, which is a plastic device used by anesthesiologists in order to keep the airway space open. As you can see over here, those are the Gadel cannulas. They have different diameters and different lengths in order to keep the airway open. And this is a clinical situation where you have the Gadel cannula inserted into the patient mouth. Another way to control the bleeding is to pull out the tongue in order to liberate the airspace, to apply some bimanual compression downward from the floor of the mouth and lingual surface or mandible and upward from the submental skin, or pressure along the inferior border area of the mandible and the antegonial notch to stop facial artery bleed, or pressure at C4 transverse process to slow external carotid artery flow. Another anatomical landmarks that we can have and we should take care of is the genial tubercles or spine. Usually they are 2 or 4 on the lingual aspect of the mandible, and they are giving attachment for the geniohyoid and the genioglossus muscle. As you can see here on RMI representation, this is the genioglossus, and those are, as what you see here in black, are the genial tubercles, and you have attachment over here from the tongue till the bone. On a cross-sectional CBCT cut, this is how we can see them: 2 bony elevation, or sometimes 4. On a cross-sectionals, also bony elevation. Sometimes they are too small, barely seen, and sometimes they are more developed, as you can see over here, and sometimes they are more and more developed, as you can see over here. We have to be very careful whenever we have some bone resorption, because as you can see, we will lose too much bone, and the genial tubercles are now higher than the residual bone level over here. Let's see this case. At that time, we didn't have cone-beam CT, so we did on what we have on board. This is a panoramic reconstruction, and we wanted to place some implant anteriorly over here. And this is what we thought we have as height of implant. But when we did a perpendicular X-ray to it, which is a lateral ceph, in order to see the height, as you can see, this is what we have as bone, and those are the genial tubercles. They are higher than the bone. And if we are looking anteriorly, we can see that we have the whole height of bone, but in reality, we do have only this one. On a CD representation, as you can see, this is what we thought we have, and in reality, this is what we have. Another case also, as you can see anteriorly here, we have some height of bone, but look, when we did our cross-sectional, those are the genial tubercles, and this is the residual bone over here. I see the representation, and look how much the bony resorption can be and how much the height of the genial tubercle can be. Let's see this case. It has nothing to do with implantology, but this is a rare case. It's one of 8 cases worldwide. As you can see, this is a female, 82 years old, and she has some fracture of the genial tubercles after having an accident, a car accident. And as you can see, the genial tubercles are detached, and they are floating into the submandibular space, as you go over here, and the tongue went back. And this is how the patient finished out with some also hemorrhage at the region of the anterior mandibular space. Between the genial tubercle, we have the lingual foramen. In reality, it's not a foramen. It's a canal going inside the mandible. As we can see it on cross-sectional cut. So we can see it on axial cut. Usually, it's at the level of 10.3 millimeters from the crestal border of the mandible, but for sure, if we have some resorption, the height will be much more decreased. Usually, it has a descending direction going from up to down. Depending on the situation, it may be more steep or less steep according to the anatomy of the bone. This is how it looks on cross-sectional on CD reconstruction. And we can even trace it with some line as we do for the inferior alveolar canal. We are using the same feature into the software in order to trace it if we have a referred patient for another dentist. Nowadays, we are working with some small field cone-beam CT with a high resolution of 76 microns, and look at the difference on how we can see this canal if we are working with a 4 millimeter resolution or a 0.25 millimeter resolution or 76 microns. For sure, on 76 microns, we are seeing better images, and this is what we call our everyday CBCT use. Usually, the canal is in the middle, and we are placing implant, mesial and distal, to it. So we are not touching it. But look at this case, for instance. I don't know why the dentist did one implant in the center with a T reconstruction in order to rehabilitate the whole mouth of the patient. Okay, and this one was really in the middle above the lingual foramen or lingual canal. Or this situation also where we have 3 implants, 1 in the middle and 2 on both sides. And if you look at the cross-sectional, the middle one was just a little bit up from the lingual canal. We do have some anatomy aberration. As you can see over here, the canal is not in the middle. It's a little bit to the left. And if we are placing implant a little bit to the left, we can hit it. Another anatomy aberration situation where you can see over here, instead of having 1 canal, we do have 2 canals, 1 in the middle, 1 to the right, and 1 to the left, and we don't have anything in the middle. The cross-sectional, in the middle, we don't have a canal. We do have 1 on the right and 1 on the left. Cedial construction also, 1 on the right, 1 on the left, and nothing in the middle. Other cedial construction also where you can see both canals on the left and the right. Also some anatomy aberration, clinical anatomy aberration. As you can see, this is the sublingual artery, the right one, and this is the left one going inside the bone without any anastomosis. So what is the problem if an implant hit the inferior canal? Let's see a little bit about the anatomy. About halfway between the upper and lower edge of the mandible, the 2 sublingual arteries will do some anastomosis and give a 1 to 2 millimeter descending branch into the mandible. And if we see this fluoroscopy, this is the border of the mandible, and this is the canal, and the anastomosis going inside the mandible. The anastomosis has a diameter between 0.7 and 1.8 millimeters with a blood flow of 0.7 to 3.7 milliliter in a minute. And if you look a little bit at the literature, you can see that the blood flow of 0.2 millimeter per beat of 70 beats per minute can possibly cause 14 milliliter of blood to escape in 60 seconds. In 30 minutes, we have approximately 420 milliliter of blood going up. So what's the problem? The first situation is when our drill will injure the artery, the anastomosis, without cutting it. It will bleed into the bone, and if we are placing implant, probably it will stop due to compression. The second situation is when our drill will cut completely the anastomosis. For sure it will bleed into the bone, and placing the implant will stop the hemorrhage. But if you look a little bit at the literature, you can see that some articles are talking about on the osseous bleeding during implant placement may disturb the wound healing processes and will lead to proliferation of endothelial cells of the blood vessels around the implant surface and possibly compromising integration of the implant. So instead, at this particular point, instead of have osseointegration, we will have some fibrointegration. But the most dangerous situation, the third one, when we cut the anastomosis going inside and the rest of the artery will prolapse and it will bleed into the sublingual space over here. And the patient will finish up by having the same situation as if we perforate the lingual cortical. The tongue will go up and will stop the respiration for the patient. And also the patient will have some respiratory distress and we have to do some intubation, or having the Gadel cannula in order to liberate the entrance of the airways. And if we look at the literature, we can see that we have 16 documented occurrences of fatal or near fatal postoperative hemorrhage following implant placement in the anterior mandible since 1990. And the most common finding in standard text is the presence of midline anastomosis of sublingual arteries entering the lingual aspect of the body of the mandible. So we have to be very careful whenever we are placing implant in the middle of the mandible, or if we perforate the lingual cortical of the mandible. So if we are doing some lingual flap, as you can see over here, we are always sparing this region because we have the anastomosis coming inside over here, inside the bone. And if we cut it, we'll have some hemorrhage into the sublingual space over here, and the patient will suffer some problem, even if after doing the sutures, because the blood flow will be so slowly, and after finishing the our surgery, we'll see that the tongue is raising up and the patient can suffer from a respiratory distress. If you look more carefully, especially if we are looking at small field with some high resolution, 76 microns, you will see that we have what we call inferior lingual canal, which is another canal a little bit deeper than the first one and going from outside to inside, but this time it's an upper direction, not in a descending direction like the first one. And also it will house a descending division of the anastomosis of the sublingual artery. This is how it looks on axial cut, and generally it has a large diameter. This is the direction. And if you look carefully over here, you can see that it has different direction and different diameter. And this can cause problems. As you can see here, it has a large diameter. If we have some, if we are going deep and we have too much resorption of the bone, we can touch it. If you look at the literature again and again, you see that they are not called upper and lower lingual canal. Some of the literature, especially Young, is talking about superior and inferior genial spinal foramina. It's the same canals, the superior one or the lower one. Here it's according to the genial spinal foramina. So if they are at the same level of the upper one, we can call it superior. And if they are at the level of the lower one, they call it lower foramina. So if you look at the literature and see the both nomination is designing the same canals. If you look a little bit more deeper, you can see that we have what we call the submental canal, which is how the lingual the division of the sublingual artery, or a branch of the descending anastomosis of sublingual arteries. As I said before, sometimes we have the sublingual, we have the submental, and sometimes we have anastomosis between them. But what we have is a group of arteries going inside the mandible. They are not in the middle. They are a little bit away from the mid-center of the patient. As you can see over here, this is one. And here you can see two entering the lingual aspect of the mandible. And if we are going deep during our drilling, we can hit them. Look at this case. This is the mid-center of the patient. And we did a cut a little bit mesial to the center of the patient. As you can see here, they were placing an implant. And they did some perforation of the lingual cortical over here. And they hit the submental artery, and the patient finished up by having some bruises, as you can see. This is not too much dangerous, but we have to tell our patient that this is nothing. It's only like a trace of our surgery. We have to make him feel more comfort before sending him home. So if I have to recapitulate a little bit, this is the lingual canal, this is the inferior lingual canal, and this is the submental canal. If you look a little bit at some more anatomy aberrations, sometimes we have different canals going inside the anterior region without having any specific names. As you can see over here, we did some oblique cross section of the patient in order to follow the path of this one. And here it is going inside the mandible, as you can see over here. Buccally, we have what we call the superior genial canal, which houses a buccal genial part of the submental artery, as you can see over here. They are not important arteries. Sometimes whenever you are doing some bone graft anteriorly, you can see that we have some pissing of blood going outside the bone from here. They are very small arteries, and we don't have any problem in cutting them during our flap reflection. If you look carefully, you can see that all the arteries and canal are doing some anastomosis between them, and this is why the anterior region is very rich in blood, because we have lots of blood supply going from or entering the mandible from different aspects. I will show the video again. As you can see, we have anastomosis over here, we have anastomosis over here, buccal, lingual canal, inferior lingual canal, submental canal, buccal submental canal, and the whole region is well vascularized. Sometimes we have what we call interalveolar foramen. As you can see here, they are at the level of the crestal bone. And if you look also at the literature, you can see that it's a branch from the sublingual arteries, which have two twigs, one medial twig entering the bone between the central and lateral incisor, and another one lateral between the incisor, the lateral incisor, and the canine. And those are the twigs going inside the bone, as you can see here. So only by reflecting a lingual flap without taking care of them can lead to some bleeding over here, and we have to do something. They are not large arteries in order to cause patient distress, but we have to control the bleeding anyway. As you can see over here, according to Rosano, we have two sublingual arteries going at the level of the crestal part over here, and those one have a large diameter, so cutting them will cause some problem for the surgeon and for the patient. This is how it looks on axial cut, on a 3D representation, and on cadaver dissection. As you can see over here, those are the interalveolar canal, the lingual canal, inferior lingual canal, and submental canal. And if you look at the mandible from the inside, you can see we have lots of holes for the irrigation of the mandible. As you can see also here, we have the lateral interalveolar canal, and here another one. We have also what we call the intraalveolar canals. As you can see over here, there are canals into the bone. And if we look at some anterior frontal view, as you can see over here, we have canals into the anterior mandible, and especially when we have a patient suffering from periodontal lesion, we have an enlargement of those canals because the region needs blood, and we have an enlargement of the canals. On a lateral view, this is the canal going from the anastomosis over here up and opening at the level of the crestal bone. If I have to be a little bit more posterior, I will be talking about the incisive canal, which is the end of the inferior alveolar canal housing the neurovascular bundle, the inferior alveolar neurovascular bundle. This is it. Here we have a lesion, and this is after doing the dissection, and we can see the incisive canal or the incisive neurovascular bundle. On a 3D representation, as you can see, this is the inferior alveolar canal housing the inferior alveolar neurovascular bundle, the mental foramen, the mental part of the inferior alveolar neurovascular bundle, and this is the incisive canal continuing anteriorly till the incisive region over here. This is how it looks on an axial cut. We cannot following it from the beginning till the end since it will do a curve, but it has a length of around 19.8 millimeters and a diameter between 0.4 and 2.9 millimeters. As you can see over here, this is the right one and the left one, and we have always a ramification, anterior ramification over here between the right one and the left one. So we have one canal till the lateral, then we have or the lateral or the central, depending on the case. Then we have an anastomosis between the right one and the left one, like a vascularization of arteries and neurovascular bundle. Look here, this is a cross-section, this is a panoramic reconstruction where we can manage to see from the mandibular foramen, the inferior alveolar canal, posteriorly, reaching the mental foramen over here, then it will continue anteriorly till the middle, and here we have a ramification going from the right side and anastomosing with the left side. So this is the right incisive canal and the left incisive canal. And if you look at the cross-sectional, you can easily see them from one side to the other side. Sometimes, and due to some bone resorption, the inferior alveolar canal is completely over the crest, as you can see over here, and on a CD reconstruction, as you can see over here. Jacobs did some high-resolution MRI, and in order to see what's the content of this canal, and he proved that it has a true neurovascular bundle having a sensory function. The canal contains the interosseous extension of the inferior alveolar neurovascular bundle supplying the mandibular anterior teeth. So if you look again at the anterior region, for sure, as I said before, we have the lingual canal, the inferior lingual canal, the submental canal, the buccogenial canal, and here we have the incisive canal. And the whole system is doing anastomosis between each part of the anterior vascularization of the mandible. Let's see this case. This is a 42-year-old female. She had dysesthesia following placement of an implant 10 millimeters anterior to the mental foramen. She didn't have paresthesia, she had dysesthesia, which is a wrong feeling. It's not a numbness, it's sometimes like pain or some burning sensation, but it's not a numbness. The patient are not feeling paresthesia in her lower right lip. We did a cone beam for her. And as you can see, there's an implant placed here, 10 millimeters anterior to the mandible, to the mental foramen. I'm not discussing the position of the implant, it's too close to the canine, but look, it's not touching the mental foramen over here. When we did a thinner panoramic reconstruction, you can see that this implant is touching the incisive canal over here. So we went and searched the literature in order to explain for the patient what she has, and we find that dysesthesia may be caused by injury to the incisive nerve. The patient may not exhibit paresthesia. The injury is anterior to the sensory division, but due to some Wallerian degeneration, the patient will feel pain and burning sensation. And this is the case of our patient over here. The neurosensory dysfunction may be partly due to the large diameter of the incisive canal. Incisive bundle may cause implant osseointegration failure by migrating of soft tissue. As I said before, whenever we have soft tissue, either an artery or a nerve or whatever in contact with with the implant, we will not have osseointegration. We'll have a kind of fibrointegration in this particular region. And if you look also at the literature, you can see that approximately 24% of subjects may report altered sensation in the short term after implant surgery in the anterior region. The problem appears to be a transient one, with only 1% experience sensation changes 1 year after implant surgery. So it's not without any complication placing implant into the anterior region. Sometimes we may have some altered sensation for the patient, like a wood sensation alteration, or the patient is feeling some burning sensation or some pain. into the anterior region simply by touching the canal. If we go a little bit more posterior, it's not typically in the anterior mandible region, but more posterior. We have what we call the lateral lingual canal, which will house an anastomosis between inferior alveolar artery and the sublingual artery. As you can see over here, this is the lateral lingual canal. And if you look at the literature again and again, you can see that those gentlemen over here and the lady, they compared the CT finding with anatomical finding of the lateral lingual canal entering the mandible, and they found that after selecting adult cadaver and doing some CT for them, they found that dissection of the cadaver mandible demonstrated a branch of the sublingual artery entering the mandible, also a little bit more posterior. So the region from, let's say, the premolar to the other premolar is very rich in vascularization, and we have to be very careful about this region, especially if we have perforating the lingual cortical plate or doing some drilling into this region without counting the anastomosis going inside the mandible. If you look at those axial cut, you can see that we have a canal entering inside the mandible from the lingual aspect till, I will show it again. As you can see, we have a point here going inside the canal from the lingual aspect of the mandible, and it will anastomose with the inferior neurovascular bundle at this site. And here is it on a cross-sectional cut. To conclude my presentation, I will talk a little bit about the anterior Staphny defects, which is an impression of the sublingual gland over the lingual cortical plate in the anterior mandible. Usually we have it posteriorly over here under the inferior canal, and this is the impression of the submandibular gland. But sometimes, in very rare case, we have it anteriorly, and it's impression of the sublingual gland, as you can see over here. And we have to be very careful about it, because sometimes we can think this is a residual cyst, but after doing the cone beam CT, you can see, and this is what we call the anterior Staphny defect. As a conclusion, I can say that good anatomy knowledge, coupled with some good radiographic interpretation, along with some good treatment plan, will lead to a problem-free surgery. What I mean by problem-free surgery is like this bird. This is what we call a cool bird. A problem-free bird walking on this automatic ramp, as you can see. Then he will fly again and come back. This is what I call a problem-free surgery. And thank you so much.
Thank you, Dr. Khairallah, for your presentation. It was outstanding as usual. In the name of all audience, I would like to thank you again. And I don't know if there is someone who has a question in the comments right now. No? So thank you very much, Dr. Khairallah, and have a nice evening, and hope to see you soon in person.
Thank you, Dr. Ali, for hosting me. It was a pleasure for me.
Thank you very much.
For sure, I will wish luck for all the other participants, and for you, for sure.
Thank you very much, kind of you. Thank you very much, Dr. Khairallah. And our next guest speaker is Dr. Ihab Rashid from Dubai, UAE. Welcome, Dr. Ihab. Dr. Ihab? I can't hear you, Dr. Ihab. Please, could you please use your headset, maybe? And unmute your mic. No, I can't hear now. A little bit interruption in the voice. Can you hear me now, Dr. Ihab? Dr. Ihab?
Yes, you can see me. You can hear me now?
Yes, I can hear you now.
Okay, very good.
So welcome again, Dr. Ihab from Dubai, United Arab Emirates. It's a pleasure and honor for me to be with you again, Dr. Ihab. We met together many times in person before COVID crisis in Marrakesh, Agadir, Morocco, and also in Tripoli. And I hope to see you soon in person, Dr. Ihab. The screen is yours. You can start, Dr. Ihab. Thank you very much again.
Thank you very much. Thank you, Ali, for the invitation to talk in this conference with the great speakers. I've been watching the first two speakers were showing very nice cases, and I hope this conference will be useful to the audience. I'm going to start my presentation with this little video. Today, my topic will be talking about osteodensification, and also we'll be talking about socket shield technique. These are the new trends that everyone is seeing in the social media and many presentations. I'm going to show you how to use these new techniques in our daily practice to enhance our outcome from the surgeries that we do on daily basis. So from looking at this video, we could see that we utilize the technique of socket shield, and this is done in a premolar. And I want to explain a little bit about this technique, how to do this. So basically, the socket shield was a technique that was invented a few years back, and we didn't have enough support of the studies and literature, but now it's lots of studies showing that it's a very predictable and very useful technique to use to minimize the amount of loss after extraction. So basically, the idea is to leave a part of the tooth here, which is the that we can see on the buccal wall, which is here, this area. And we can see that this part of the root will eliminate or reduce the amount of bone loss on that very thin buccal that you can see on the image here. So basically, we leave
Sorry, Dr. Ihab, if you can hear me, it's a little bit interruption. If you can, please be close to Wi-Fi, maybe you can continue.
Is it better now?
Yes, but the internet is a little bit interrupted. Could you continue now?
Okay. Is it? I hope it's clear now. It's okay now?
Yes, it's okay, please.
All right. So we go back to the point that we were showing earlier, that we have the part of the root that we leave it here, then we do some vertical cut, and then take the palatal part out, and then we start delineating more palatal, and you place the implant just as a normal site of the extraction. But what we have to do, we have to make sure that we don't touch this part of the root when we are going to place the implant, because this is one of the main reason of failure. How do we do it? Start this technique. We can use this kind of a kit that there is many kits in the market. This is the kit I use frequently. This is done by my colleague Dr. Darcio in Portugal, and basically these kind of very long shank bears that used to go all the way to the end of the root to cut the root to the tip. And then also there is different kind of instruments that I use to elevate these kind of root particles, and I usually use these root laxators. We don't use any forceps. We never use any kind of normal elevators. This is called the laxators, because basically though between the palatal bone uh,
Dr. Ihab, sorry, there are many interrupted sessions in between your talk. I don't know if you can make sure that you be close to the internet, because from my side, I think it's okay. If you connected with mobile internet, I think it always happen like that. It should be Wi-Fi. Dr. Ihab, we can't hear you. We can't hear you, never. Still internet problem right now. Please leave the studio and re-enter again, maybe resolved. Make sure that your internet is strong. Okay, so we'll be back soon with Dr. Ihab after he fixes his internet problem. Now it's my pleasure and honor to welcome Dr. Markus Engelschalk from Munich, Germany. Welcome again, Dr. Markus, for this event. You are a very special guest for us. You joined us last summer in June in the summer dental meeting, and now in this second edition of the Mediterranean dental meeting. Welcome, and you can share your screen. Just I have to clarify that we make just a little bit change because Dr. Ihab has a problem with the internet and he will join us later. So just we switched to a presentation between Dr. Ihab and Dr. Markus. So Dr. Markus, the screen is yours. You can start, please.
Perfect. Thanks a lot. Hi, Ali. Always a pleasure to work with you together. I hope you can see my presentation now, because on the screen I just have my presentation.
Yes, perfect.
Perfect. Okay, then let's start and have the next 45 minutes. Very interesting topic. And honestly, I'm happy that the root membrane technique wasn't that explained too much, because I will also highlight a little bit this in my lecture, because it's very interesting and I would say very a future technique we should use and we should all think about it. But let's start from the beginning. Today, I want to talk about the biological impact of modern implant systems, and this combined with digital dentistry. And I don't want to name any brands today because that's not important. I just want to show you some critical points and some important points we have to look at if we think about biology and implant placement. But first, thanks again for the introduction, and it's a short CV of mine, and I'm happy to be with you together. I'm always happy to stay online or offline in your countries. So let's have a look to the lecture today. And the topics I will highlight with you are very easy. Primary, secondary stability, ISQ and ITV. These are two values which are very important for us. Guided surgery, of course, immediate implant placement, the one abutment at one time concept, and intraoral scan bodies, because these topics are very important for us if we talk about the biology and the implants. And that's why we have to highlight them. Okay, let's start with primary and secondary stability. So we know that osseointegration is very, very important for us. And I brought you a case here of mine. And when we extracted the tooth, and we promised before, and that was a big mistake, to the patient that we can place both implants, then we placed the implant in the molar region, and it was, yes, of course, it was stable if the patient is jumping, but you won't load anything on it. And we augmented this with only xenografts around and PRGF. And finally, this healed so perfectly, and the bone healed around the implant very perfectly, so that we could bring a bridge on it. And this was from June 2018. And now he needed some implants on the other side. So we made a CBDC scan, and we could see the perfectly healed bone around the implant. And the question is always, what's the reason for that? And one reason is for sure the primary stability, because primary stability is the key for success. And if we talk about the influence of biology on implants, or the influence of implants on biology, we have to talk about the shape of an implant. And therefore, for me, it's very important today not to name the brand. I can tell you the brand I'm using, but it's more about the shape, and it's more about the philosophy we need for an implant. And of course, we don't have always very tight bone. We also have type 1, D1, D4. We have diabetes in the patient. So we have a lot of osteoporosis. We have a lot of influences on the bone quality. And I don't want to highlight the vitamin D problematic today, because this should also be an interesting topic to talk about, but this is very important. So, and if we look at this, we know all these curves. It's dental implant stability. And we know at the beginning we have the primary stability. This is caused by the shape or the threads of the implants. And after a while, after some weeks, this is increasing, is decreasing, and the secondary stability is increasing. Means that the bone which is growing onto the surface of the implant is getting better and better. And now we have an exchange of the two stabilities. So this is still to look at, because even if we use another modern implant system or whatever, we still have to respect the biology. And this is very important because we won't change biology. You can't buy a quicker biology with money. It's depending on the bone, it's depending on the human. And if we look on primary stability in different types of bone, I will show you this picture, because you see from the left to the right, it's a different kind of bone. And if you place a normal implant as you do every day, then it's the same thing. So, but for us, it's clear that the primary stability in the different classes of bone is different. So in D1, the primary initial stability is way higher than in D4 class. So what was the result, or what is our consequence? So first of all, we tell the patients, just wait longer. Yeah, just give the bone more time to heal. And this is the reason why sometimes we can go immediately on implants, or wait 1 month or 3 months, and sometimes we wait 6 months. And think of the old healing classifications done by Bronnemark decades ago. And we said in the upper 6 months, in the lower 3 months to wait. Why? Because of the quality of the bone. And if we think about new implant systems, then we can change this. So if you now have a look on this implant system, on this kind of shape, you see that the core, the body, has the same diameter, has the same shape. But what's different? The threads are different. So that means that the difference in diameter is not of the implant itself, it's more the threads of the implant. And if we place this now, and if we look at the initial stability, then it's clear that with the huge threads on the right side for D4, we can create nearly the same initial stability like for the D1 bone with small threads. So this should be a solution, or this should be a possibility. And the reason for that is very clear, because if you look at the pictures and if you look at the X-ray, we have this, because on the right side you have the compressive necrosis just because of the threads, and on the left side you have the minimization of the compressive forces. So because the threads are different, the angulation of the threads are different, and sharing the heat or sharing the pressure on the bone is way different than before. So this is very important to keep in mind. Even if they are all self-tapping, the cutting edges and the non-cutting edges maybe play a major role for that. And we have to respect this theory if we think about the biology and the implants. So the next thing, if we talk about primary stability, is ISQ and ITV. These are two measurements. Maybe you heard about it. For sure, ITV is well known for everybody. It's the insertion torque value. It means these are the 25, 30, 35 Newton centimeters you're using to screw in your implant. The ISQ is the implant stability quotient, which is measured by a resonance frequency system, and which can give you an idea how stable your implant is. But start from the beginning. Primary stability, as we already said, can be seen as an absence of clinical implant mobility, which is quite clear. So if it's stable, then it's not movable, and it's imperative for osseointegration and success. It means the primary stability is the key for success. It's the same if you have a broken arm, you have to do a primary stability for the arm by a gypsum cast to keep him strong and let it heal. Well, normally we say the insertion torque value we need for that is around 25, 35. This is depending on the implant system you're using. And by showing you the different kinds of threads, now you get an idea why. And sometimes we have studies with insertion torque value over 75, 100, 120, and normally would say, oh, this will cause a necrosis, something. That's not true, because it's depending on the implant system. An insertion torque value over 50 Newton centimeter is not good or bad for every system. So we have to rethink this theory. The next thing is that the insertion torque value is only be done at the time of implant placement. So we can just measure it at the time of implant placement. If you want to know if your implant is stable after the healing period, you're not able to use insertion torque value anymore, because otherwise it will be something like a explantation torque value. So this is only once giving you an idea of the stability. But later on, if you want to measure it, no chance. So what to do? The next thing is that we can say the implant stability quotient can be measured at any time. Means you can measure it at the time of implant placement, you can measure it at the time of uncovering, or you can measure it before or in between the prosthetic reconstruction. So this is a value we can talk about the whole life of the patient with his implant. Well, factors influencing the early load possibility or the stability, the primary stability of the patient is the age. It's his bone density and, of course, the volume of bone and the class of osseointegration. Well, often we know that if the primary stability is low, we will risk an early failure, or we don't have to load it immediately. So don't promise a patient that you can do immediate implant temporization. We will see once later, but you can do it if the insertion torque value and the ISQ value is perfect for that. Well, the next thing is that you always have to cross-check the measurements of your implant to be safe and to be sure. So let's have a look deeper on that. The ISQ value is changing over the year, over the months, and over the weeks, depending on the implant system. Some implant systems, like the shape I showed you with the big threads, they keep their ISQ value over the time. And for some, the ISQ value is shrinking and rising again over the time because of the change of primary and secondary stability. Well, if you measure the ISQ, you have a perfect tool with the patient to communicate, because then you can tell him, let's wait a little bit, or yes, of course, we can restore the implant. And if you have referring dentists, it's the same. You can tell the dentist about the ISQ value, and you can start to refer the patient back to his dentist. Well, let's get it clear. Normally, it's a statistical thing between 0 and 100, I would say, but if we have values over 70, then it's perfectly stable, and then it's really like cemented into the bone. If you have values around 55 or less, then this is a clear warning sign for you. In between, I would always wait, because 70 or higher is the value we are aiming for. Well, we know that from the curves that the primary stability is changing into the secondary stability, and we have a decreasing stability during the first months. So over the next months, this will change. And as I told you already, we will get again higher ISQ values. So if we look at different kinds of implant system, and here you see this, it's very interesting to look in the literature, because then we can see everything. And the resonance frequency measurement, well, we're doing this in our office now, I would say since 2010, something around that. And the devices changed. At the beginning, they were very ugly and not very designed. Today, you get them from nearly every company, even implant companies are selling them. And they're beautiful designed. And the best thing we have now in our office is a small, like a pen, and it's easy to handle. Yeah, so this is something I really would recommend. So let's have a look again on the implant threads and the implant design. If we look at this implant system, believe it or not, the core of this is always the same. It's 3.3 millimeters. So you now know that the diameter of the implant is not changing in the core, and the platform is always the same, but it's changing in the threads. If we talk about an implant with a diameter of 4.0 versus an implant with a diameter of 5.5, then we're not talking about the bigger amount of body of the implant, we're talking about a bit of bigger threads. And if we go further and we extend this, we can also use implants with a diameter of 8.0. But for 8.0, the body, the core is 4.8. So if you imagine you use an 8.0 in your traditional implant system, then you would need a lot of bone, because then the implant itself is 8.0. You need 1.5 around, and this is nearly a situation you will never have. But in this case, you just need 4.8 in the middle, and the threads will do the rest. So, for example, 7.0 to 8.0 is ideal for an immediate implant placement in the molar region. Doesn't matter if it's the upper or the lower molar. The thing is, if we can do this or not is depending on different things. It's more depending on the anatomy. It's more depending on where the sinus floor is. If do we have enough height? So this is a different case, but you can use this kind of design way better if you want to do some immediate implant placements. And this is also a prerequisite we need from modern implant systems, talking about the biology. Well, bringing the two values together, that's the ISQ and the ITV, we can have recommendations, of course. We have for single missing teeth, we can see which ISQ do we have, which ITV do we have, can we combine them? And for example, if everything is over 75 and 45, you can do a single stage immediate loading. If it's lower than that, ITV is lower than 10, means that's very sweet drilling in, then you shouldn't do this, because even if the ISQ is around 60, it's not helpful. So this is very important, this recommendation. And we have this recommendation also for the multiple missing teeth. So if you do a splinting for a bridge, and now you see that the values are changing a little bit. If we compare, if you look ISQ over 70, ITV over 40, and you look for the single tooth, then you see ISQ is over 75 and 45. So because being splinted in a multiple missing case, then we can talk about a slight shrinkage of the values, of course. And if we do the full edentulous, now you see that the stability is more around 65 or higher, or ITV is more around 30 or higher, because it's a full arch splinted system. So ISQ and ITV values are very important for placing implants and for the decision if we can do an immediate temporization or not. So this is something a modern implant system should give you as an answer. Yeah, that's the high stability is by the cross arching. Okay, the next thing, and honestly, I have no experience with that, not yet, because we're not available in Europe to have it guided, and I'm a digital man and I'm a guided man. The ossedensification. The picture I saw already, and I don't want to look at the picture on Instagram. I need the pictures from my colleagues, because Instagram, you know, it's not always golden there or true, but picture from colleagues, they're very impressive. And ossedensification is something which is depending on the shape of the drills and the shape of the burrs using. And at the moment, I would say it seems to be very, very helpful for us in the future, placing implant in the upper jaw. It's because the threads and the kind of drilling is completely different to the traditional way. And it's a procedure where you're gaining bone. And as far as I can see from the literature, this is something we can use in the future. Well, now we will leave the biology and just looking more to the guided surgery, more to the implant placement itself. Is there anything as a request we want to have for modern implant system and biology? Well, of course, if you look at guided surgery, and we in our office do nearly every case in guided surgery, even if it's a single implant placement, if you look into the literature, and this is something published in 2017, then they told us that the only evidence was that the implant survival rate and the effectiveness are similar to conventional and digital implant placement procedures. So that means on the first view, we are not better. It's not different. But they also mentioned that we will reduce the post-operative pain, surgical time, and the costs. And this is something very important. And this is something we see every day in our office when we perform guided surgery. We way quicker because everything is planned already in advance. And for the patient, it's much less pain, less swelling because of the tremendous reduction of surgical time. So this is very important to see. And I think if we can do a benefit to the patient, then we should do this. And often it's more clear because sometimes the opening of the mouth is not that wide. And if you want to place an implant in the region of the second molar, then you have to be sure that your implant is placed in the third dimension perfectly, even if you have a location guide where you just tap on the bone where the implant should be, but then the drilling is made by your hand and by, I would say, brain guided, which is also good, but you have to be very sure, and therefore it's sometimes more better. If we look at the kind of guides we can use, more and more we're doing them printing by our own. In our office, we're printing them by our own in our office, but normally even in the labs, they will be printed. And there are some guides with sleeves or without sleeves. And well, talking about the accuracy and the fit and the trueness of guides, we have to talk about the movements of the drills. And even if you use a CBDC scan, even if you use a drill guide, then you can't be sure that you're 0.2 millimeters beside the nerve. That's too dangerous because you will create some kind of artifacts of failure or the difficulties during a CBDC scan. If the patient is moving, or if you have more gold metal crown reconstruction in the mouth, then you have these artifacts in the CBDC scan. And this is a chain of possible mistakes you can create. So it's perfect, the guided thing. It's the same thing if you do it not guided or if you do it just by gypsum models. You have the same problems, but we have to be aware of these problems. But the guiding means that the implant is nearly placed at the position where we want it, with the length, with the diameter, and for the later prosthetic reconstruction. Because in my mind, the prosthetic reconstruction is the best peri-implantitis prevention we can get. And then we can discuss, do we have metal sleeves inside the guide or not? We are printing now guides without any metal sleeves in our office because it's much more easier to handle and the precision is much higher. So this is what I can show you. This is a study from 2014 already, and they compared several guided systems, something from Noble GaiaCAD, from Ostem, from MegaGen with the AutoGate, which we are using now in our office, MegaGen, which is, for me, it's the best and easiest implant and guiding system we can use in this case. So the accuracy is very important, and this is always depending, or often depending, on the question, do we use a metal sleeve or not? So this is something you have to respect. That's what I told you already. And now we're going to the guided surgery itself. I want to show you some pictures. So this is a case where you see there are 3 implants planned in the upper jaw. Of course, we see that there is a need for sinus floor elevation. And of course, we can see this on a 2D radiograph also. But in this case, you see that with the green lines, you see the future tooth, the future tooth shape is planned. And we can plan directly the position. And now we can see, can we do a screw retained crown? Can we do cemented? What about the abutment? What about the position? And we also can talk about the amount of sinus floor elevation we need. And you can also discuss, is it possible to do it simultaneously because of the bone height we have already where the implant might be fixed? Or should we do it in a 2-step way? So this is very important for me to see. Beside the question that we can talk about structures like nerves, we can plan the surgery right at the beginning You can talk about need of membranes or not, the abutments. If you want to reconstruct it directly with a provisional or temporary, you can talk about this already at this time. So this is very important. We can go through this case very quickly. You see these are the areas we are planning it. And this is now the shape of the guide. And at this guide, you see that there are holes for control windows, as we tell them, or we call them. You got the implant position where you drill it, and you get sometimes, if it's not only related to teeth, or maybe it's not fixed, you have fixation screw holes where you can fixate the guide on the mouse. So this is the situation printed. You see now the printed guide. You can see it's without any metal sleeve. And even if we design the guide in a way like this, you can perform the sinus flow elevation even with the guide in the mouse, and you can use it later on for drilling your implants. So this is also a request for modern implant systems, that we are able to plan something in a planning software with our implant system, which is quite important in a way. And the most important thing in my mind is to place an implant also through the guide, because if you do immediate implant placement, sometimes it's already difficult to drill a hole into the extraction socket. Sometimes the bony walls are pushing your drill into a different kind of direction. You don't want to. So for these cases, the guide is helping you. And the same can happen if you want to insert the implant. Mostly the palatal wall is very, very strong. And if you think about placing an implant in the front area, then we have to go more palatal. But this may be sometimes not so easy because of the bone. So in this case, we placed it, and it's not about placing the implant parallel, because I believe that all of you are able to place implants parallel, but it's more about the position of the implants, that later on, the crowns are perfectly seated on these implants, and we don't have any gaps, any ridge steps, and any corners where peri-implantitis can start. In this case, you see now, this is a model from the intraoral scan of the implants at a healed situation. You see on the right picture above, you see the screwed crown and the crown on the tooth. And on the lower picture, you see the situation of the guide. So, and I will show it directly to you. You see now this surgical guide. This surgical guide was done by a different kind of intraoral scan months ago, in this case 7 months ago, and we printed this with a different printer. Now you see that the guide is still fitting on a printed model, scanned 7 months later with a different kind of scanner and printed by a different printer. But it fits. And this is, I would say, these are miracles of digital dentistry, but this is working. And if our implant system is able to work in this way, then we have the perfect answer to the biological requests. You see now these crowns on the left and right side, and now you know what I mean. The implants have to be placed at the right position, that the crowns are beautifully designed by the lab technician in a way it should be. Yeah, that's the bad thing. This also works with fully arched edentulous patients. Of course, in this case, you see that we had to fixate the guide with fixation screws. And we could bring in, we've been able to bring in the temporary screwed at the same position screws to fixate it on the provisional abutments, and then remove these screw holes from the provisional, because you have to fixate it somehow, otherwise you will lose the bite of the patient. So if we talk about guided, and I already mentioned it very often, then we will talk all about immediate implant placement. And the immediate implant placement is coming up more and more in our office, I would say, because we want to keep the bone, we want to keep the structure. Sometimes, yes, of course, we want to avoid a second surgery or third surgery, but mainly we want to keep all these structures. And this was highlighted already perfectly by the lecture before me, which I hope we'll see the rest after my lecture now. It was perfectly done. And because the idea of root membrane technique is to keep the bone, but we will see it later. So immediate implant placement has nearly a very, very high survival rate. if we look into the literature. This is always very important. If we talk about something new, we have to prove that it's successful. So this is my only case of the root membrane technique, as we call it. You can call it root membrane technique, you can call it socket shield, whatever. We do it as a root membrane technique with the set from Mitzas Miltiadis, it's a Greek dentist. And so in this case, we had the problem with the tooth 1-1, and we removed the crown, we cut it up, the abutment of the crown, and then we planned everything in advance. Now you see why we need this to rebuild this front tooth. And in the front area, it's always a challenge because we have to deal with soft tissue, we have to deal with aesthetic, we have to deal with the missing tooth, pillars, and everything. So for me, in my world, it's mandatory to do a CBDC scan, to do an intraoral scan, and to match everything together. And in this case, we did a first view on the quality of the bone. You see it here in the software of AutoGate. Now we can judge by the yellow and blue and green colors. We can judge a little bit the quality of the bone. And we can already plan the implant position the best way combined with the root position, and the best way combined with the later abutment position of the tooth. And then we extracted everything, and for not extracted already, but before we extracted, so let me get this clear. We inserted a guide just to cut the root by a drill in the axis we want to, because we needed to have the bigger part of the root, the palatal part of the root, to be extracted, and we want to keep some part of the root. Therefore, we do it digitally, guided, and then we can shape the root, which we will left as a shield in the socket. And then, in addition, we use a second guide just for the implant position. And as I already told you, that sometimes if you do immediate implant placement, there are deviations of the drills. In this case, we needed also this guide for drilling the right position, especially if you have a socket shield there, to keep it in place, not to hurt it, not to move it, not to vibrate too much on it. And this was very, very perfectly done by the drills and by the guide. And now you see the result. And you see 1 week later, you nearly see nothing. And in this case, we've been able to reconstruct it immediately by a printed provisional, because the ISQ and the ITV value was perfectly. And the same is nearly possible in the lateral premolar case. But in this case, we haven't been able to keep the root. So you see there's the tooth 2-4, there's a huge cyst we have, and we have to remove it, and we have to place an implant. And the patient was begging us to do the immediate temporization. But we can't promise it because we don't know the ITV and the ISQ value at the same time by planning. We just know it at the moment of implant placement. So this is the prefabricated provisional, and this is the guided splint. And this is the situation. This is just the planned situation. And we want to transfer this planned situation into the real situation, because at this time, the tooth wasn't extracted already. So we planned everything, and then we came to extract the tooth. And then we drilled the hole for the implant. And we placed the implant through the guide. And you know there's more to do. And then we opened up the flap. And now you can clean up everything. You can fill up with xenograft in this case, and you can use the membrane. And now you can recognize that at the moment of augmentation and at the moment of membrane placement, you see that we already placed the provisional. The reason for was to create the best soft and hard tissue modulation around this provisional already. So this is also mandatory for a modern implant system, that we are able to produce prefabricated provisionals, that we are able to have these ISQ and ITV values to do this. And at the end, this is the postoperative X-ray. You see now the implant placed. You see that the cyst is removed. Everything is built up by xenografts, and we have this temporary abutment in right height to have this crown stable. Well, if we talk about this now, we always have to confront ourselves with this one abutment at one time concept. Well, from the biology point of view, it's the best thing because we have nearly no, well, no, no, we nearly have no, bone loss. I just thought about how to tell it the best way, but there is some bone loss, of course, because of different kinds of influences, but it's completely different to two-piece implants. If you screw on your implant, if you have an implant and an abutment in two pieces compared to the one-piece implant with abutment on it, then the one piece is way better for the bone. But honestly, it's horrible for the prosthetic reconstruction because the emergence profile is always round, and there is no the round tooth. We have rectangled, eggshells, triangled diameters, but no round. And of course, the implant axis often is different than the prosthetic axis. So the one-piece implant is something difficult for us. But we know that the non-removable of abutment placed at the time of surgery, sorry, they improve the stability. They improve the stability of soft tissue and hard tissue around the implant because we don't screw in the future on this implant. The problem is that if you want to place the definitive abutment already at the time of surgery, you really have to know exactly where the soft tissue will be later. I would say for non-aesthetic cases, it's not a problem. For aesthetic cases, we can't do this. So we have to solve this problem. And going deep into the literature, you know that the consequent dis and subsequent reconnections of abutments, if you do the impression, if you do the scan, if you change the healing abutment, we will reduce the bone and we will drive the mucosal barrier more apically. So that's something we know. And therefore, we have to look for different possibilities. And the different possibility could be the intraoral scan body. The intraoral scan body could be a solution, which is not given by the impression coping. That's very clear. So this is, for example, for the MegaGen, for the AnyRich system, this is a scan body made by ZFX. Or this is the conventional intraoral scan body, which comes from the lab side. This is the reason why it's looking like this. And well, we know now that if we change it more than 4 times or 4 times compared to 1 time on an implant, we have bone loss. But honestly, in the real world, we have to unscrew the gingiva healing cap, we have to unscrew the impression coping or the scan body, we have to unscrew the scan body and impression coping, we have to unscrew the gingiva healing cap, and later for inserting the crown the same, unscrew the healing cap, unscrew the crown. So 6 times of screwing. And this is not much if we think about the workflow we have. So how to change this? And this is, for example, a possible change of philosophy. This is the healing abutment by MegaGen, which stays in the mouth and will be just combined with a cap. You click on it and you scan now the cap. So you have this white part is now your scan body, which is clicked on the abutment or the healing abutment, and you don't have to screw. The only time when you have to screw is when you will change this healing abutment with the crown, with the later reconstruction. That's the only time. And if we look into the real world, and often it's better to show than to tell, then you see this is something we can use as a normal abutment. And of course, we can create a perfect emergence profile. And of course, we can talk about the best of tissue support, but we have to screw. And we also can scan the individual emergence profile by that, but we have to screw. And if you do it with this kind of abutment, you just let it here, you just click on the abutment, and you just scan it. And then we have the same workflow, and we have the same, sorry, one quick, you have the same the design of the abutment of the crown, in this case the screw retained crown, and you can insert it, and you've been gentle to the tissue, I would say, yeah, because you just screw it 1 time at the time of insertion of the crown. So this is something we have to keep in mind. And if we want to summarize everything up, then we can say the prerequisite for a modern implant system regarding the biology and regarding digital workflows, we have to think about the different kind of threads. We have to think about the way an implant can be placed in poor quality of bone in D4 or in good quality bone like D1. So we have to think about changing the threads, not changing the diameter of the body of the implant itself. The ISQ and the ITV value is very, very important. And I think this is the secret or the key for success for us if we want to talk about loading, early loading, immediate loading. And even if you do wait 6 months, then it's interesting to have a value like the ISQ value before you load in a regular way your implants. Guided surgery for me nowadays is a must because we can guarantee the best position of the implant, the shortest surgical time, and the best outcome for the patient, because if you shorten up the surgical time, then swelling and pain will be reduced. Immediate implant placement is a possibility, of course. We have to respect the primary stability. We have to respect ISQ and ITV. Means we have to respect the shape of the implant. So that's again the biology. And we have to have a perfect view on it already at the time of planning. So means a CBDC scan is mandatory too in these cases. The one abutment at one time concept is honestly, I know it's right, but for me, from the point of view as a prosthetic dentist, I would say no, because we want to have our individual abutments. We can talk about the time when to place these individual abutments, but infrared scan bodies can be a possible solution for us to avoid damage to the soft tissue and to the hard tissue, to the bone. And these are, to sum up, these are factors which are important for the biology. So normally, if you say the topics, implants, modern implant system, and the influence on biology, it's a very boring topic. But I think if we go into the details, the last 40 minutes, they've been very interesting. And you can talk about this for hours, because this is the future of a positive implant placement. And I think about the root membrane technique or the socket shield membrane technique. This is the future, and we can keep it so perfect, and we can keep the bone, we can keep the soft tissue, and this is something we have to respect in the future. By that, I want to thank you to my scientific sponsors, I would say, and to all of them, they are supporting me in a perfect way, and was a pleasure for me staying with you again. Yeah, that's it. I hope it was some kind of good information and a kind of entertaining. Thank you so much for your time.
Thank you very much, Dr. Marcus Engelschalt, for your nice presentation. Outstanding as usual. I don't know if you are working at your office right now, but I wish you schönen Abend, nice evening. So hope to see you soon, maybe in February before Agadir event in June 2022. So thank you very much again. Take care. Goodbye. And now we are going to our next guest speaker. He's a good friend, expert, and I like his presentations. Dr. Anas Al-Musrati from Libya. Welcome, Dr. Anas, for this session of the first day of the Mediterranean Dental meeting in our second edition. The screen is yours. You can start, Dr. Anas. Thank you.
You're welcome, Dr. Ali. Thank you for this presentation, and thanks, Dr. Marcus, for very interesting presentations. I will start today to speak about the Gummy Smile which problems in static zones and problems for many who have these problems. We'll start to know what's the gamma smiles and how can diagnose the gamma smiles, what's the problems with these patients when it comes to our dental clinics, and how to treat the gamma smiles. We started about that. First, the gummy smiles is a high lip smile or high smile line or gingival smile lines. There's many definitions for it. All of them is mean that there is a gingival display about 2 millimeters or more when this patient is smiling, and some patients is feelings not good, feeling the aesthetics is not good. We want to make a good aesthetics and try to make some things more better in aesthetic, especially when he's smiling and the shows or her or his smile being white, more being not clear. The gingival display is more than 4 millimeters. So this is the main problems. There's 3 primary factors for these problems for high smile or for gummy smiles. These 3 factors is a tooth, gingival scaffold, or lip frameworks. There is another factor is a skeletal factors, which vertical growth of the maxilla, this position of the maxilla with upper jaw, with the tooth relationship with skull. These factors need consultation for maxilla surgery or orthodontic surgery to correction these gummy smiles. Other factors, 3 factors, is the dental factors, problem in the teeth, or problem in the gingiva, or problem in the lips. So you can see the gingival display, as we see here, that the gingival display is more than 2 millimeters, will look ugly, and the patient is not comfort about it. So you need to correction these smile for tooth or for gum correction or lip correction. So we speak today about these 3 primary factors, which are dental factors. Tooth or it's the problem about the tooth or about gum or about a lips. First of all, we'll start about the lips. What is happening about the lips? If some patient have a short lips, when have a short lips, the gingival display is more than 2 millimeters. We will take that will lead to a gummy smiles. The length of the lip you can measurement from the upper border of the lip vermilions to the subnasal. This is the normal length of the lip. It's about 20 to 22. If you have short lips, less than 20, that may lead to a gummy smile and more gingival display during smile. That's why you have to measure these lips and to know if the patient have short lips or have a normal lips length, that decide you for what surgery you can go and how can you treat it, these problems. Okay, the lip display in normal positions, when the lip is displayed in normal position, the incisor display is about 3 to 4 millimeters, not more than that in normal position. That's in smiling position, maybe have a different levels and different average. Okay, the amount of gingival display, normal amount of gingival display when smiling is about 1 to 2 millimeters for maximum. If have more than 2 millimeters, that means you have a gingival display and you have a gummy smile, which is look not normal, and it's some patients see it like it's ugly smile, and you want to correct these smiles. So you have 3 types of smile. You have average smile when completely the incisors and the tooth are completely exposed, and you have 1 to 2 millimeters only of the gingival is displayed when he smile. This is called average smile lines. The other types is a low. The low smile line, that means when he smiled or he smiled, you will not see or will not display the gingiva. You will see only the tooth. This is a low smile line. High smile line, when he's smiling, you will see display all the tooth and display more than 2 millimeters of the gum of the gingiva. In this smile is a high smile line. This high smile line, that means you have a gummy smiles. This is the main problems where you talk. What's the cause of these high smile lines? You will see you have three factors. Maybe it's tooth factors or lip factors or gingival factors. You have a small points you have to keep in your mind when you want to correction any types, any cause of this gummy smile. You have to keep in your mind a small tips or a small point. It's a very important. The gingival zenith. The gingival zenith. It's a level of the marginal gingiva. You have a level of marginal gingiva of incisors, central incisors, the same level of the marginal gingiva of canines. And when you see the level of lateral is less than level of the incisor and the canine, about 1 to 2 millimeters. This is gingival zenith, will give you a very nice smile. You have to know the normal component of the gingiva. As we see, we know about the marginal gingiva, interdental papilla, keratinized gingiva, mucogingival junctions. It's very important to know how amount of keratinized gingiva you have before start any types of surgery, and the length of the crown. Even these points, gingival zenith, you have to be in your mind, and if there is a disturbance in gingival zenith, you have to correct it during surgery. And the other problems which you have, delayed passive eruption, which you talk about it. Have three primary factors for dental factors. You have gingival, and you have tooth, and you have lip. The lip, if you have short lip, this is you need surgery to correction. You need fillers, you need botox for correction these problems. And the other things, the tooth and the gum. The second and the third one, the tooth and the gum. You have many problems. Maybe you have a gingival enlargement of the gum, or something to talk about is a delayed passive eruptions. Delayed passive eruptions, which means the tooth is completely eruptive, but the marginal of the gingiva is not proceed to the normal position, which is at cemento enamel junctions. So the gum is, or the gingiva, the marginal gingiva, cannot be, or it's not receded apically level to the cemento enamel junction. This is lead too short. The tooth, it's more short. It's like square. This problem is called delayed passive eruption or alternate passive eruptions. This is, you have to correction. This type of problems you have to correct them by static crown lengthenings, because the crown is less in length, square-like. When the patient is a smile, we saw a high lip smile because the gingival display is more than 2 millimeters. So when the patient is smiling, you have these problems. Is a dental problems. It's attrition of the tooth, like maybe the tooth is coming like smaller, or partial erupted tooth. This is like alternate passive eruption or delayed passive eruption. In this, the tooth is coming more short and it is square in shape and is not good, or it's not normally in shape. Or you have the last cause may become the tooth is short, is excessive gingival enlargements. For any causes, local factor cause or systemic cause, but the main point clinically, once you have a gingival enlargement, will you see the crown is shorter crown, short clinical crowns. Okay, you have to decide about the clinical crowns or anatomical crowns. As you see, the clinical crowns may become short, may become long, may become short in some cases, like attrition of the tooth inside the edge or occlusion, alternate passive eruptions, and gingival enlargements come longer, like here in this picture. What you see is about recessions. Okay, Clinical diagnosis for alternate passive eruptions and how to treat it. This is the main point, is the location of the marginal gingiva related to the cemento enamel junctions. This is the main point to make a diagnosis for alternate passive eruption or delayed passive eruptions. So you should be make a diagnosis to see where is the position, exactly position of cemento enamel junctions, and where is the exactly position of the marginal gingiva. So you can decide this is alternate passive eruption or no. Like what I see now here in this picture is a bone soundings. You see here a short clinical crowns. It's about 7 millimeters the length of the inside central incisors. The sulcus depth is about 3 millimeters. The bone sounding, once you do it, it's about to 5 millimeters. You have here 2 millimeters is a biological width, about biological width, and the position of the marginal gingiva is two above the cemento enamel junction, which alternate passive eruption, the marginal gingiva is not receded or is not going apically at the cemento enamel junction. There is a 3 millimeters missing of the marginal gingiva to be at a level of the cemento enamel junctions. So here, how to make a bone soundings. First, you have to give anesthesia for the patients, and you go the sulcus depth at about like here, so 1 millimeters, and you go more deeply until touch the crest of bone. This is about 2 millimeters. You can here decide it mesially and distally to know what is the exactly position of the cemento enamel junction and exactly position of the level of the crest of alveolar bones. You can make a CBCT for make a good position of soft tissue. See a short clinical crowns, make a probing depth. It's a probing depth about 3 millimeters. So you can open flap. You see the level, where is the level of the crest alveolar bone. You need to correct the correction of these levels. You remove from the bone about 2 millimeters to give a new attachment of epithelium and a new attachment of connective tissue as a biology for the biological width, new biological width to correction of the new biological width with smoothly reduction of the bones. And then you have suturing of these flaps in the same positions we see before and after, before surgery and after surgery, after healings, about 1 week. So you have many types of surgery for alternate passive eruption or delayed passive eruption. According to the case, you have gingivectomy, gingivoplasty. It's indication or contraindication according to the pocket depths. These pocket depths is these types of pockets is suprabony box or intrabony box. If intrabony box, this is contraindicated for gingivectomy or for gingivoplasty. If you have suprabony box, it's okay. Gingival enlargement is other causes for giving a short clinical crowns. You have to do gingivectomy and gingivoplasty for these cases for correction the level of the gingiva and the tooth display and become the normal length of the crowns. This is once you have a gingival enlargement. In other cases, when you have a gingivic, you have alternate passive eruption, as you see in these pictures, you have to measure exactly the depth of the sulcus. Then you have to measure exactly the level of the crest of alveolar bone. Then you can make a gingivectomy about 2 millimeters, about 3 millimeters reduction according to keratinized gingiva you have, according the level of the crest of alveolar bone. You have a point. You have a level of the marginal gingiva. You have a depth of the sulcus before you start any surgery, and you have the level of the crest of alveolar bone, and you have a level of cemento enamel junction to decide you go for surgery, for gingivectomy, or for static crown lengthenings. This T-bar is used for crown lintings to make a proportions between the mesodistal and length of the crown. This is, I have blue or red or black colors to decide exactly how much of bone reductions and how much of soft tissue reductions when use it. This bar is can be easily to use it and easily to determine the level of the gingiva and the amount of gingiva reductions and amount of bone reductions. So this part is helps for detection exactly how much you can remove and make for you a good proportions and good aesthetically about mesial distal width of the tooth and length of the tooth. Okay. We'll speak today about crown lintings, especially static crown lintings. Static crown lintings or crown lintings, they have a many indication and many types and many procedures for it. You have you can see a crown linting for soft tissue only. It's like a gingivectomy or gingivoplasty, and you have other types of crown linting. Is a crown linting with open flaps and remove and reduction of the bones. The indication of crown lintings, there's a many indication for crown lintings for aesthetic reason, for gummy smile, for increased filler, for correction of biological widths. See the static crown lintings. When you have a patient with static crown lintings, need static gummy smile, need static crown lintings, you have to take pictures, clinical pictures with good proportions and consult it and go with DSD for examples or digitals and select the which size and which shape of tooth they have and or the which shape and size, square, triangle, oval in shape, and make this template before starting to know how much of the gingival display you want to remove, how much of soft tissue you want to remove, the direction of corrections, angulation of the tooth, if this patient need correction only by surgery for soft tissue and hard tissue only, or need restoration or restorative types, for example, crowns, veneers. This is a digital design. Before you starting any surgery or make any surgery for gummy smile, you have to make a good diagnosis for these patients. First of all, it's a dental problems, or it's first of all is a dentist problems, or is skeletal problems. If skeletal problems or vertical maxillar growth, you have to consultation with maxillar surgery, for orthodontic surgery, for other types of surgery and diagnosis. If a dental problems like these patients, here you have to make a good clinical pictures. First of all, you have X-ray, CT with you to know exactly the level of cemento-enamel junction and to know the level of the crest of alveolar bone and level of soft tissue also, and to measure exactly these all point with us. If you have intraoral scan and make scanning for these patients, you have a 3D for this patient is more better for diagnosis. Then you can put it in digital DSD and make a template and shoot and see the proportions about the length of the crowns and how amount of gingiva you can reductions and how amount of crown how can make replace of this crown with crown or with veneers or any types of restoration according to the case. Okay, before starting surgery should be make good diagnosis completely to know exactly where's the position, how much of bone can be reduction, how much of soft tissue can be reductions. Okay, to make good completely treatment plans. The important point for static crown linting is a biological width corrections. It's a junction epithelium and connective tissue. Once you have reduction of the crestal bone about 2 millimeters, 2.5 millimeters, you give a chance for new biology, new epithelium attachment, new connective tissue attachment. This is a main point for static crown linting. It's a correction of biological width. In some cases, when you have alternate biological with it, also the patient is coming in inflammation, continued inflammation, chronic inflammation of bone. This is biological with it. Once you have less than 3 millimeters, this is you have always problems. Static crown lentings can help you for correction the biological with it, that's make less inflammation around the tooth. You can see the length of the crown is 9 millimeters. Once open flap, you see the cemento-enamel junction, and the level of the crest of alveolar bone is about 1.5 millimeters. It's a biological weighted 1.5 is alternate biological weighted. Here we go for correction. This biological weighted will go make a bone reductions about 1 millimeters more. To go up the normal biological weighted, you needed 2 to 3 millimeters. More than 2 millimeters and less than 3 millimeters. After close the flap, you see the crown is coming about 11 millimeters. It's a normal average, the length of central incisors. Other indication for the biological width is you have about the femoral length. Once you have a restoration crown, you want to put it, and should be the finish line come in the natural sound tooth. You have about at least 1.5 millimeter all around. In this case, if you don't have, you have to correct the biological width and to make your finish line more deeper to get a femoral length about 1.5 millimeter at least. Some cases, as you see, after did the static crown lengthenings, you see here the length of the crowns, just static crown lengthenings and correction the level of the gingiva with a correction the level of the bone and correction of the biological with it, pre-operative and post-operative. This is with crown and veneers. Other cases here have alternative passive eruption or delayed passive eruptions. The crown is seen as a square, short crowns. With other problems is a ratio pigmentation, is a brown pigmentation on the tooths. And once you go for static crown lengthening, open flap, the lip is okay. The main problem in diagnosis is a dental diagnosis. Go for open flap, correction of the bone level, correction of gingival zenith, correction of the biological width, and go for suturings immediately after surgery. And this is immediately after 1 week. This is immediately after 2 weeks. The gingival display is about 1-2 millimeters. The length of the crown is about 11 millimeters with normal proportions. Mesodistal, it's okay. In this case, no need for restoration, no need for crown or veneers, just correction by static crown lengthenings, and the patient is have a normal smile, average smile line, gingival display about 1-2 millimeters, not more. It's because the main problems is alternative passive eruption only. This is other cases which have a gingival display more than 2 millimeters. We go for static crown lengthenings, correction the gingival zenith, and correction of biological width. Then you see preoperative, during surgery, and after 2 weeks of post-op 2 weeks. With length of the crown about 12 millimeters, which normally gingival zenith is normally. The gingival is not completely healed. Will come conditioning and creeping later on. Will come goods. Now we can go for small tips. Small tips about surgery of static crown lengthenings. So we can. So we can summarize some things before we go for the next video. Once you have a gummy smile, you have a multiple problems. As I said before, there is skeletal problems and dental problems. Skeletal problems need consultation with maxillofacial and orthodontic surgeries, and the dental problems is 3 factors. Dental factors: tooth, or gingiva or lips. Okay, you can the lips, you can go for lip repositionings or for fillers and botox for these problems. The tooth, you can go for veneer or restoration according for your diagnosis, what you did. And for the gum, you have to go for static crown lengthenings. Static crown lengthenings. We will give you some tips about static crown lengthenings. First of all, some cases, if you have enough keratinized gingiva, you can start with a gingivectomy to correction the zenith before start of static crown lengthenings. At day of surgery, then we can go for flap. The second tips, when you go for flaps, you have to go with flaps with a split thickness of flaps. Okay, and then you can go correction after reflection the flap. The flap, when you flex the flap, do not go more than the mucogingival junctions. Don't make a reflection more or beyond the mucogingival junctions. Okay, to be stable, the flap in the same position. Okay, and less post-operative. Will you see all these steps on next video? It's static crown lengthenings for patients who have a gummy smile. A gummy smile, it's about more than 2 millimeters. Make a digital for this patient to know exactly if need correction or no of teeth. CBCT to know exactly the position of the crest of bone and the position of the cemento enamel junction, exactly the zenith, where is the point of the zenith or amount of gingival display. You see, open the flap here, split thickness flap, thinning of the papilla, the palatal papilla is still stable in the positions, splitting thickness flap, not more the mucogingival junction, refraction of the flap, not exist the mucogingival line. Okay, we start to correction of the heart, of the bone, of the heart tissue now, start correction to remove any bone exostosis here, you see, and slightly correction the level of the bone and make a new biological with it. It's about from the cemento enamel junction to the crest of bone, it's about 2 millimeters, 2 millimeters, 2.5 millimeters, not more than 3 millimeters. Always the reduction of the bone away from the cemento enamel junction, not more than 3 millimeters. It's 2 millimeters. The ideal is 2.5. It's perfect. Will give you very nice gingival zenith. You see, be careful for zenith of the canine with the zenith of central incisors. It's at same levels. Zenith of the lateral incisor is less. Okay, the zenith of lateral incisor is less. After correction, the zenith here, correction of the zenith, you see here, correction, the amount of the length from the cemento enamel junction to the crest of bone, it's about 2.5 millimeters. We see here calibration, the length of the crown, how is the length of crowns. Reduction of the bone. Be careful for zenith. You have two zenith. You have zenith of bone and zenith of soft tissue. Zenith of soft tissue always we correct it before start, before open flap. The tissue is still fixed. Make a correction of the zenith before start. After open, and go be careful. Keep in your mind the zenith of bone. The soft tissue will rest it on the bone. Once you have a difference level of bone, you will go with a different. You will found a different level of soft tissue. The same level of central incisors with same level of lateral incisors is very important. The zenith of bone is important, like the zenith of soft tissue, like the zenith of the marginal gingiva. Okay. After complete reduction and correction the zenith and correction the biological, now you have to make the bone, it's like a smooth knife edge. There's no exist of bone, there's no sharp edges. Okay, you have with the large diamond pair, you have to correct the marginal bone, make it like smooth. There is no knife edge to be the when once the make a flap and adapt the flap again. There is no any interference with healing. There is no sharp edges for the soft tissue. You have to make all which bone which you have reducted with smooth, with large diamond pair. Okay. After complete smoothings of the all bones, all soft bone which you are reduct here, you see this is another tips. When you have a thick intradental papilla, once you have a thick intradental papilla, before go for suturing, come and make thinning from the inner surface, from the connective tissue. Make a thinner of the papilla. Okay, make a thinner of the papilla. The point it's before. This is one point again. Sorry. You can see here.
Yes, it's okay.
The thinning of the papilla here, the thinning of the papilla, and now make after thinning of the papilla to be good adapter and good tissue on the crown. Before start suturing, make a position of the flap again in the same position. Okay, then and go with a gauze, mutured with saline, and go with the pressure on the flap to any blood inside come out. These steps will help you for post-operative edema, post-operative pain, post-operative bleeding for 5 minutes. Hold with gauze for 5 minutes. Okay, leave it to hold it in the same position. The other things we go here for suturing. It's a type of suture is a vertical matrix sutures. We start from palatal side, okay, and go in the base of the papilla and come back from the buccal side. Then we go to the palatal side. Then your knot is in the palatal side to decrease the scar. This is for decreasing scar after healing. Okay, if you leave the knot in the buccal side, will you see after 10 days or 2 weeks, the position of the knot in the same position of the suture here, you will make a scar in this suture. You are working in the static zone. If you make this vertical palatal incision, you will don't have these problems, which is a scar in the tissue on the buccal side, in the labial side, in the static zone. Okay, we start first suturing. First note, you start in the middle. Okay, you start in the middle to be the flap in the same positions. Then we'll continue from other sides. This goes with mutures and leave a pressure on it for 5 minutes to go any blood inside the flap and to be corrected and very well. Okay. Make a good calibration. Here you can start with a lasers, start to correct the zenith of these central incisors, after complete suturing. Or you started before, you make with a lancet, you can go for gingivectomy, okay, before you start and before you open your flap. Okay, thank you so much. Thank you for listening. Thank you.
Thank you very much, Dr. Anas, for your nice presentation. It was really great pleasure and honor to have you today. And see you soon.
Thank you.
Have a nice evening, Dr. Anas. Thank you. Thank you. Bye-bye. And now we are going to our next presentation. It will be with Dr. Thamer Deeb from Amman, Jordan. I think right now Dr. Thamer is on trip, so we recorded the presentation in advance. I hope that you all enjoyed. I will let you now with the presentation of Dr. Thamer Deeb.
Hello, good evening, everyone, and good morning from here, from the United States of America. Hopefully, you're having a good evening and a good course today. Many great speakers were presenting during the day. Hopefully, you had fun and a great knowledge. I'm sure of that. This is Dr. Tamer Deeb. I'm a prosthodontist, and today I'm gonna speak about the prosthetic understanding of full mouth implant supported prosthesis. We need to plan and visualize a comprehensive approach of understanding these cases and how to fully understand these cases even before we starting such a procedure. Most of the cases we're gonna see today are a collaboration between me and my lab ceramist Guglielmo Prazzili from Milan, Napoli, and I hope you're gonna enjoy these cases. And most of the information and knowledge we're gonna provide today is part of what I teach in the university and as part of I teach with the British Academy of Implant and Restorative Dentistry. And I hope I see as many of you soon, inshallah, in many different countries. We operate in more than 11 countries with more than 1,700 dentists already participated in our courses during the last years. So I will start my lecture with a question. How often do you see this? Okay, in your dental practice. This is a case you can see a full mouth rehabilitation case supported by implant. The implants are surviving, as you see, but this is a failure. You can see this is an aesthetic failure. This is an occlusal failure. This is a mechanical failure. So you can see here we have an inverted occlusal plane and inverted smile line, bad aesthetics, bad occlusion. The patient complained of inability of chewing and having a normal life. So though the implants are surviving, but here is another form of failure, and this form of failure we are seeing too much nowadays because we have good implant systems, we have an easy process of osseointegration, but we still lack the good knowledge and good education about prosthetic rehabilitation of such cases. And I will say most importantly, poor planning of such cases. This is the main cause of failure, poor planning. So I would love to say that failure has too many forms, okay, and most of this mechanical failure, okay, and we see it a lot, as I said, because of dentists are applying the same prosthodontic principles of natural teeth, and they just take it as is and apply it to implant dentistry, and this is not correct, regardless of the kind of prosthesis. Regardless, we are restoring with acrylic or porcelain fused to metal or zirconia. Okay, nowadays we have different forms of mechanical failures that we see a lot, especially with full mouth implant supported prosthesis. It's well known for everyone that treatment planning is the key of success of is the key for a successful treatment and any kind of treatment. But unfortunately, in implant dentistry and for full mouth rehabilitations in specific, we do not have a specific protocol. Okay, all of what we see, we do not have an evidence-based knowledge how to treat, how to restore such cases. And most of what we see and what we read is a kind practitioners' experiences. Okay, so I'll try in my lecture today to have like a protocol how to understand these cases, how to think of each case, and how to restore each case successfully. Nowadays, we are lucky, and unfortunately for the same time, we have many options and to restore implant supported prosthesis. For example, you can support it with acrylic dentures, post-infused to metal. You can use zirconia. When we talk about zirconia, you can do monolithic zirconia, you can do cutbacks, you can do full layered zirconia. We have hybrid prostheses, we have different types of glass infiltrated, like the beak or the picton prosthesis. So we have many different options to help us restoring such cases. But at the same time, this will also make the treatment difficult, or it's difficult to choose between too many materials for the dentist, and how to understand the right choice for such material. Let me start with such a case. You can see here, I have an upper arch, okay, most of the teeth, or maybe financial reasons, the patient decided not to restore the lower arch. He said, let's start with the upper arch, and I will do the implant now, and maybe later I will go and restore the lower arch. Okay, so what are the material of choice? What is the best material? I'm asking you, what is the best material I can choose from to restore the upper arch in such a case? As I said, you can do dentures, you can do acrylic, you can do zirconia, and each material will give you different strength and different aesthetics. So I'm gonna ask you here, what is the material of choice? And remember, always finances will play a role, the availability of material, the skill of your dental technician. So what do you think is the right material for this case? Okay, so as I said, many materials we can use, but for me to restore this material, I basically considered one thing: the cost. Why? Because the patient, in my decision for such a case, I will go for the cheapest material. Why? Because I cannot build an ideal occlusion. So I told the patient, okay, let's go for a metal the patient an ideal occlusion. So I prefer to wait, not to spend his money on treatment that I might need to change later to adjust the occlusion. So this will give you a hint how to understand the situation and how to think before starting the rehab, how to think of the future and the importance of the occlusal plane and providing an ideal occlusion for such cases. Okay, so for most of the cases, and I will like to start here with such a simple case. Okay, this patient needs to restore or to implant one tooth. I think this tooth will need an implant. Okay, and this might look easy. Okay, I need to implant, but as we know, implanting a central incisor not usually the easiest thing to do. But in this scenario, for a single implant restoration, I would love to show you how should I think with this case. Okay, so before you start any case, you should start with a smile design and treatment planning, and you can see I need to adjust the level of the central incisors. Okay, you can see we have different levels here at the central incisor. So we will need to do crown lengthening for the natural teeth. And you can see I have a large diastema here, okay? That also will make my treatment or my decisions more difficult. So I decided to veneer the adjacent lateral incisors to enable to get more control over the case or the aesthetic outcome. So here in such a case, I need to adjust the incisor level, the smile line, I need to distribute the spaces, I need to close the diastema, and I need to get the implant in the right position, okay? So always I start my case with a smile design, and I evaluate such a design with a mock-up with a silicon index, and I can see here before starting the treatment that I have good outcome of my planning. So before starting, I ask my patient, is this outcome, is this satisfactory for you, or we need to enhance something? So the patient accepted this, and I need to move this now into practice. So what I will do, I will test the occlusion. Is this results satisfactory? Do I have good anterior guidance, the good posterior disclusion? I need to test everything. I need to test the phonetics, the smile line. Everything should be tested before starting the treatment, okay? And after that, I will implement my design. Here I'm using the R2 gate system, okay? And you can see we are using the wax up or the digital wax up and the digital design to plan the future position of my implants, so I get everything in control before even starting the treatment. So you can see here the planning and the final position of the implant, relying on the aesthetic smile design we did before. So you can see we end this with this R2 gate guide to place my implant. Also, I will use my printed guide here to have a plastic sheet to guide me where to and how to cut the gingiva and to do the crown lengthening procedure. So using my smile design, I were I was able to place my implant in the right position, and I had the knowledge where to cut or where to make my cuts for the crown lengthening procedure. And you can see we started with the crown lengthening, we made the cuts, then we extracted the tooth, we placed the implant guide, we placed the implant, and because this is a digital procedure, you can see that we have the temporaries are ready made even before starting the treatment. You can see now we are filling the gap and suturing everything in place. What's interesting here is the accuracy. You can see the before and after are exactly typical to the design we did, okay, and everything was under control because of good planning and good understanding of the case. So this is a general hint how to understand and how to read such cases, okay? Before you start with any case, you need to know and to evaluate the success and the failure factors that are in such cases. So usually I divide my patients into a low risk, medium risk, and high risk patients. Okay, it's very important to understand and change the patient's habits before starting the treatment. Okay, patients with low risk factors are our favorite patients, also the medium one, but patients with high risk, usually they are more susceptible and more prone to failure again, even if you do implant supported prosthesis. We all know, for example, if patients have periodontitis, usually he will end up with peri-implantitis. So you need to evaluate the success and failure and the risk associated with this treatment before starting the treatment. Okay, so for the treatment planning for such cases, I start with understanding the etiology and differential diagnosis of the case, the space and I have and the dimensional requirements for this case, the number and position of the future implants? Can I go for guided surgery and immediate loading? Can I do this? What's the framework design for the final prosthesis? What is the material I'm choosing? And what is the opposing arch material, or do I have a natural dentition? And finally, how I'm gonna do my occlusion. Okay, this is very important before starting the case. So first, understanding the etiology and the differential diagnosis, why the patient became edentulous, okay? And this is very important, okay? Usually, a patient with attrition, previously broken restorations, bruxism, periodontitis are high risk patients, okay? And for such patients, you will need, okay, a high strength ceramic material, and you need and a shock absorbing opposing arch. We need to control the periodontitis. So for high risk patients, okay, it will raise a question how to manage such case. Okay, it will be more difficult to understand or to deal with such case when we compare it to the medium and low risk patients. So whenever you see attrition, bruxism, and I'm here talking about prosthetic high risk factors, okay? Previously broken bridges or restorations, this will give you a hint, okay, we need to deal with such a case differently, okay? So, as we know, bruxism, it's unlikely to be a risk factor for the biological complications, okay? But it might be a risk factor for mechanical complications. And as I said, today in this lecture, we're going to focus on the mechanical complications of such restorations. The second thing we need to understand is when we do our treatment planning, the space available for the future restorations, okay, the space and dimensional requirements I have, okay. So you can see here, if I'm gonna use a zirconia frame supported restoration, okay, I'm gonna use zirconia frame restoration. First of all, if I'm gonna do such a restoration, I will need 10 to 11 millimeter here. You can see for the average length of central incisor, I need 10 to 11 millimeters. Then I will need 2 to 3 millimeters for the pink part, and I will need 2 millimeters here for the implant component. And I need the frame, okay, or the transitional line between the gum and the frame to be away from the smile line by 3 to 5 millimeter, okay. So we can say if I want to do implant zirconia frames or zirconia frame supported rehabilitation, I need to have at least 12 to 16 millimeter, okay. You can see this. So if I don't have such a space, okay, here as I said, 16 millimeter at least for such a restoration, you might consider another options, or to do ceramic restorations without pink part, or to use another material. So it's very important to understand how much space we have in order to give these beautiful zirconia frame supported prostheses. They provide us with strength and high aesthetics. How to understand this? Very simple. For any full arch case, I deal with it as a complete denture patient. So I start with my base plates and wax ups, and you can see here, planning this case, we can decide the lip support, the smile frame, the incisal edge position, the vertical dimension. And it's very important that these cases all we work at the centric relation. We need to reorganize the occlusion and have it at the centric relation position. So as we do with complete denture patients, design the case, okay, and we can evaluate the space we have, okay. We can evaluate the space we have using our or utilizing these wax rims, okay. After that, after placing the implants, for example, this is a low risk patients, okay. So we decided to go with metal frame supported acrylic dentures. They're gonna provide us with high aesthetics and good cushioning effects for double arches, and at the same time high aesthetics and cheap cost. Okay, the trick in these restorations is the metal frame and especially the passivity of such frames. Okay, so such cases can be, we can deal with it easily if we can have passive metal frames. So you can see here we did use printed acrylic material, and now we are doing we are checking the occlusion, and you can see such materials are very easy to use and will give you very nice and high aesthetics results. Okay, uh, what I do really like about these restorations, it's they are very easy to fix. For example, if you have a fractured tooth or a fractured uh, uh, part of this full restoration, they are very easy and cheap to fix. Also, I do understand most of these one piece restorations are not easy to clean, but because it's screw retained restorations, I also ask my patients to come every 6 months to clean these restorations and screw them back in place. Sometimes, if we do not have enough space, what we do surgical adjustment for the ridge. For example, if I need to contour my emergence profile, you can, nowadays we are blessed having this digital technology. We can guide and we can cut into the ridges and shape the ridge the way we want to do understanding and to provide the space. As I said, if you don't have 12 or 16 millimeter to do the zirconia restorations, it will be difficult. So sometimes if I do not have a good vertical dimension, what I can do is to shape the ridge to have such a space. Another factor we need to consider, okay, is the strength of the material we need to do or we need to use. Okay, so for example, let's talk about this nice material. Okay, every material has different behavior and function and fractural strength. Okay, for example, if I want to do zirconia frames restorations, okay, I need around the screw, around axis 2 millimeters at least all around the axis screw. For example, for the connectors, they should be at least 7 millimeters anteriorly and 9 millimeter posteriorly. Okay, so having a space or such a space is mandatory to provide my patients with zirconia frame supported restorations. Okay, now if I have more space, I will have much more options. For example, here I have good space, as you can see, posteriorly around the screws, anteriorly. Okay, so in such a case, I decided to use a glass reinforced polymers such as the beak or the picton. And these frames, the advantage of these frames, in my opinion, what I like about these frames are their weight. Okay, they have they're much less weight than the zirconia frames. They are light, and I can load these frames with Emax or single zirconia restorations. Okay, and you can see at the same time we have highly aesthetic restorations that I can fix and I can deal with easily. Again, here the hygiene might be difficult and you need to emphasize the recall for visits for the patient. What I need to do or what I need to understand before using such restorations like the beak and the picton, that I need more support. I need more space to provide the exact strength for such material. For example, in this beak, we need at least 12 to 14 millimeter connector dimension, so I can provide my patients with such restorations. Okay. Now, for full mouth rehabilitations also, It's a question how many implants I need and where to place my implants. Okay, and to be honest, this is a dilemma, and this topic is you will have different opinions and different factors, okay, regarding this, the number and position of dental implants. You will see dentists doing full arch rehabilitations using 4 implants, and some dentists, they will prefer to use 6 or 8 implants to restore a full mouth. To be honest, I can say easily you can do anything. It's case dependent. I'm happy to use 4 implants to support a full mouth prosthesis, and I'm happy to do 8 if the patient or the case can afford this. So this is how I distribute my implants. Generally speaking, I would prefer to have the maximum anterior posterior spread. I prefer to place 1 implant anteriorly, as far anterior as I can, and 2 implants posterior, as far posterior as I can. Okay, then I prefer to place a safety implants. For example, if any of the implants fail, I will have a safety implants helping me not to lose the full case. So you can see here I place 1 implant as a safety implant anteriorly and 2 implants as a safety implants posteriorly. Okay, this is the basic distribution for my full mouth implant supported cases. But if the patients can afford and I have good bone, I can also minimize the Pontic numbers, and I can minimize the cantilever and the stress associated, also placing another 2 implants. So you can see this is how I think when I distribute my implants. 1 implant anterior, as far as anterior as I can, 2 implants posteriors, and 3 safety implants. That's it. If I can afford, or the case can help me affording 2 implants more to minimize the Pontic size and to minimize the stresses, I will place another 2 implants. But you can see you can and we are able to provide full mouth cases using 4 implants, very easy. And how do we do this? The same, okay, the same protocol, the same procedure. We start with the smile design, designing the case, evaluating the case inside the patient mouth. If this design is satisfactory, we're gonna send this to the implant for example, the R2Gate system, to know the position and the ideal position of my implants. And you can see here we use this design to place 4 implants. Okay, after that you can see this guide helped us to place 4 implants easily, and though we needed to graft the area here, okay, we're gonna end up waiting 6 months, then placing an acrylic supported with a metal frame final prosthesis. Honest, I have this slide here to emphasize that though you can see most of the procedures we did or I did in this seminar are digital, okay, for implant or for full mouth supported prosthesis, usually we need a lot to do, or a lot of knowledge to use the digital treatments or the digital concepts to finalize the treatment. Okay, so I don't really like to use the intraoral scanners for full mouth rehabilitation impressions. Okay, but if we did that, okay, you need to understand or to make sure that these metal frames are passive. Okay, usually they will not as passive as we want. So what we do is to cut these inside the patient mouth and re-weld them to re-ensure the passivity. Okay, once we ensure that we have passive prosthesis, okay, I will continue with the treatment as a full mouth or the full denture case. Very easy. So as I said, the difficulty of such cases is to plan the case. Okay, make sure that the frame we have is completely passive, 100% passive, and after that I will continue with the treatment like with complete denture patients. You can see here we are testing the results, the vertical dimension, the smile line, the phonetics, the occlusion, and you can see after we are sure of everything, we can convert such restorations, we can scan it and convert it into final BMMA material, okay, supported by metal frame on 4 implants, okay. And why I do like BMMA, because of they are easy to fix, they have good support, and they do good cushioning effects for the final restorations, and at the same time they will give you nice aesthetics. You can see here we have nice aesthetics using only 4 implants, okay. So again, you can see that the trick of, or the message I want to give you is, first of all, to understand the case, to understand the limitations we have, the risk factors. Again, I'm talking here mechanically, okay. Then using digital planning to understand, to place your implants. So I'm, I want to say that flapless guided surgery is the treatment of choice if there is no need for bone grafting or bone reduction during implant placement. So whenever I have good ridge size, I don't need to bone graft. Good treatment planning. You can see here, now we are lucky that we have this technology that we can do guided surgery easily and to understand the case completely before even having or doing any flap. So whenever possible, I will do it guided, okay, and whenever possible, I will do it immediate, okay. One note or something important to talk about, that the surgical guide should be fabricated from the diagnostic wax-up, okay. This is very important. Do not do your surgical guides from the patient existing dentition, okay. We need the surgical guides to be built on ideal occlusion and planning to our final restoration. So you can see we are using our smile design, our wax-up, our denture teeth, to plan to guide us to the future implant placement position, okay. Now, for example, if I have this case, and you can see here we have a habitual class D patient. As I said before, most of these cases we need to plan on a centric relation position, okay. So I will start readjusting or reorganizing the occlusion, and you can see here this wax up is my future placement for the teeth, okay. Now, after having or discussing this treatment with the patient, okay, I need to send this to my R2Gate system, and now I'm using this plan to place or to construct my my implant guide, where and how I'm gonna place my final implants. Now listen, very important, okay. It's I can do immediate placement, okay, immediate temporization whenever I have a medium and low risk patient, okay. I need certain conditions, okay, to do so, but I can summarize it that I need my implants to have at least 35 Newton as a primary stability, okay. I need cross arch stabilization, okay, with the screw retained rigid prosthesis, no cantilevers if I'm gonna do immediate restorations, okay. I need no premature occlusal contacts. This is very important. No lateral interferences, and I prefer to have canine guidance, okay. And I need minimal horizontal and vertical overlap, okay. If I have all of these conditions available, okay, I'm happy to do or to immediately load my implants, okay. You can see here we started the case with this guide. The most important factor is to make sure this guide is stable, okay, very stable, okay. And you can see we are lucky because of this technology. We are able to easily place 8 implants, I think in less than 1 hour in each arch. Now this is immediately after we are done with the implant placement, and you can see we immediately took the impression and immediately placed a metal frame with acrylic supported with the metal frame prosthesis. Okay. Now the same steps we do for, as I said, for the uh, single restoration or the complete denture patient. We need to make sure of the occlusion, the aesthetics, the function, the phonetics. I check all of this, and you can see here we did some welding for the case, okay, to ensure the passivity of my metal frame. Now, once I'm happy with this, okay, I'm happy to give the patient an immediately loaded provisionals, okay. Now, we needed to wait about 6 months, I think, or 4 months before finally loading the procedure. I have the frame ready, okay, the design of the frame already here. We have everything, and because we are in synthetic relation, okay, we decided to load this frame with a zirconia layered restorations, okay. And you can see we have a very nice aesthetic outcome, very nice function, occlusion, okay. And you can see this is how we started the case, and this is how we ended such a case, okay. There is no magic here, just good planning and good treatment choices, okay. So if we talk about, for example, about zirconia, okay, we need to understand that we can do zirconia in 3 different techniques. You can completely layer it for more aesthetics. You can do cutback technique. You can do monolithic zirconia restorations. And what will tell you this is the risk factors. For example, for high-risk patients, we will prefer to do monolithic zirconia. For medium risk patients, I will prefer to do the cutback restorations, okay, to enhance the aesthetic. We will have the lingual side full in zirconia and the facial side completely layered, okay. But for low risk patients, I might go for more layering and more aesthetics. So you need to understand the space and the risk factors for the patients to know and to understand which technique I'm going to use to finish my restoration. So this is something to consider when dealing with zirconia frame restorations. Another thing or another option I would love to point is using the zirconia frame. This is a nice option I actually love, using a zirconia frame that is supporting acrylic crowns, okay, be a polymethyl methacrylate acrylic crowns, okay. Why? Because here we are combining the strength of the zirconia, okay, and having at the same time very easy and cost-effective option, which is the PMMA crowns, okay. These are very cost-effective. They are cheap. They are easily fixed. You can fix them using composites. So this option you might consider. Again, if you have low risk and medium risk patients, okay, they will give you nice aesthetics and nice and one more cost effective options, okay. And for example, you can use this to cut the cost. For example, if you are having a full zirconia frame in the upper arch, you can use this, for example, for the lower arch, or vice versa, to have or to control the forces we have in such cases, okay. So occlusally, again, I'm not afraid of the occlusion when we talk about biology and the bone loss, okay. But usually occlusion will be accompanied, occlusal problems will be accompanied with more mechanical issues and mechanical failure, okay. Please let me finish with this case, okay. You can see here again a patient with periodontitis. You can see maybe this is the longest bridge I ever saw. We have a failing dentition and periodontitis, and the teeth are needed for extraction, okay. So you can see here that this patient is he was on this prosthesis for a long time now, and I need to adjust and make sure that my occlusion is perfect before proceeding to the final restoration. So you can see here, this is a very old case. We did guide the treatment, and we did place 6 implants in each jaw, and because we have good stability, we decided to send the patient home with a metal frame supported denture. And again, if you want to do dentures, you need to do this on centric relation position, and this is the most relaxed position to the mandible, so the patient can have a more comfortable position and more support and good support for the restorations with less occlusion issues. Okay, so this is very important to reorganize the occlusion in such cases. Okay, now the patient was on these stems for, I think, for 4 or 5 months. Okay, and this was he was satisfied with the results both aesthetically and occlusally. Okay, so in order to transfer this, and as I said, this is an old case, I need to scan this nowadays, but at that time we did make an impression for the denture, so our lab technician nowadays can duplicate the biological borders of my previous restoration. Okay, so we did the impression, and we decided to go for zirconia frame layered restoration. Okay, so you can see this is the wax up, this is the silicone index, and my lab ceramist need to fill the gap here with the zirconia and ceramic restoration. Okay, so before proceeding to the final restorations, we started testing this with polymethyl methacrylate restoration. This is the try-in, and now I need to check the phonetics, the occlusion, the everything before proceeding to the final one. So you can see here the patient is happy and satisfied with the polymethyl methacrylate restorations. Okay, we scan this now and we ask the lab to duplicate this. So you can see this is a full zirconia frame, and we decided to layer this frame. Why? To have more aesthetics. The patient occlusion is centricylation, which is the most relaxed position. The patient is a low risk patient. Okay, so I'm happy to do a fully layered restoration, and you can see the final aesthetics come, how nice and how beautiful are my final restorations. And to have this long lasting, again, we need long lasting and highly aesthetic restorations. I need to make sure I have perfect occlusion. I have perfect occlusion, and you can see this X-ray, I think 1 year or 2 years immediately after the implant placement. Okay, this is how we started the case, and this is how we ended the case. So this was fast. Hopefully we're gonna see you soon, inshallah, in Libya, بالعراق, in different places, and in person. In person, please feel free to contact me or to ask me anything you need about this topic or any other topic. Thank you all for attending this, and hopefully we'll meet each other very soon. Have a good night.